Okay, assalamu alaikum everyone. My name is Safia Elhassan.
It's
Recording in progress.
Sorry about that. And today we'll be giving the CVP OSPE review session. So Shahad and I really tried to make this as comprehensive as possible, and hopefully you guys will be able to benefit from it.
Yeah, so we're going to be covering all of your cardiology labs, and then we're going to move on to your pulmonary labs. And then quickly, we're going to discuss the physiology labs, both the the cardio one and the physiology one, inshallah. And we'll be like explaining and also adding questions here and there, so you can, be as interactive as you can in order to benefit. And yeah, inshallah, this will be helpful.
Okay, so our very first topic is thoracic skeleton. So before we start talking about all of the organs and the blood vessels, let's just take a moment to learn about the skeletal muscles, or the skeletal structures that surround all of the organs that we're going to be talking about. So the thorax, it's the area of the body that's located between the neck and the abdomen, and it is bound by a lot of bony structures. So anteriorly you have the sternum, posteriorly you have the vertebra, and on the sides you have the ribs, and then there are also a bunch of muscles and ligaments that help support this structure. So let's start by talking about the sternum. So the sternum is a wide and flat bone that's located anteriorly, and it has three parts to it. You have the manubrium, which is the most superior, you have the body, which is in the middle, and you have the xiphoid process. So let's start off with the manubrium. So the manubrium has an articular site for a clavicle, so it articulates with your clavicles on both sides, and it also has a jugular notch. So the jugular notch, you can actually feel it. If you start at your clavicle and you go more medially, you'll be able to feel the jugular notch. It also has an attachment site for the first rib, and it joins the manubrium at this angle called the manubriosternal joint, or the sternal angle. And between them, you also have the articular demifacets for rib 2. So rib 2 can articulate with the sternum and the body at the same time. The body is the longest part, and it has the articular facets for ribs 3 to 7. And then the last part is the xiphoid process. And the joint between the body and the xiphoid process is called the manubrio-xiphoidal joint. Okay, so now let's talk about the sternal angle of Louis. So we already mentioned this briefly. The manubriosternal joint, or the sternal angle of Louis, it's this protrusion that you could feel. So if you start at your jugular notch and you go down and you feel this ridge or this protrusion, this would be your manubriosternal joint. And this is a very important landmark because it actually marks the attachment of the second costal cartilage to the sternum, right here. So once you locate this, you can go up or down and count the intercostal spaces and the ribs to get to whichever rib you need to get to. So when it comes to the ribs, we can classify them according to three different classifications. So we can classify them by features. So by features, they would be considered typical or atypical. We can also classify them by attachment. So they would be considered true or false. And we can also classify them by articulation. So that would be sternal versus chondral versus floating. So let's just talk about typical ones first. So typical ribs, they all have the same general characteristics. They all have a head, they all have a neck, and they all have a body. And in the head, they all have two articular facets. So one articular facet, that is for articulating with the numerically corresponding vertebra, and the other one is for articulating with the vertebra above. So as an example, let's imagine this is rib number 5. This facet, the one that's more inferior, is going to articulate with vertebra number 5, and this facet, which is more superior, is going to articulate with vertebra number 4. And then we have a tubercle. So a tubercle, this is located exactly at the junction between the head and the neck, and this is for articulating with the transverse process of the numerically corresponding vertebra. And then you have the body, or the shaft, and this contains a costal groove, which is just a groove for intercostal neurovascular bundle. So the neurovascular vein, artery, and nerve. So the typical ribs are ribs 3 to 8, and then every other rib is considered atypical because they do not follow these general characteristics. So let's take a closer look at rib number 1, which is an atypical rib. So right away, you can notice that the structure of this one is a little bit wider and flatter, and it's also much, much shorter compared to the typical rib that we just saw. Let's start off at the head. So previously in the typical rib, we saw that the head had two articular facets, In rib number 1, it's only one articular facet. And when it comes to the tubercle, this tubercle is a lot wider compared to the tubercle that we just saw. And in the body, so the typical rib had one costal groove. This rib has two costal grooves, or two grooves. The first one is for the subclavian artery, and the second one is for the subclavian vein. So here are all of the ribs side by side, just to give you guys a better understanding, so you guys can actually compare the features for yourselves. So this is a typical rib with the head, the neck, and the body. And this is an atypical rib, specifically rib number 1, which we just looked at. And this is rib number 2. So one thing that's really unique about rib number 2 is that it has a tuberosity for attachment of the serratus anterior muscle. And this is rib number 11, which is an atypical rib, and it's floating. Okay, now let's talk about rib fractures. So say you're working at the hospital and a patient comes to you, he was just in a car accident, and he has 2 broken ribs that you saw on chest x-ray. So where do you think these fractures would be? Okay, so you would see this fracture typically at the ankle, and that's because structurally the angle of the rib is the weakest site. So if you have a rib fracture, it's very, very likely to happen here. Now this is if we're talking about typical ribs. When it comes to atypical ribs like rib number 1, the fractures of it are very uncommon because you guys saw the structure of it. It tends to be a lot stronger than typical ribs, and also the clavicle protects it. Now let's talk about attachment and articulation. So what does attachment mean? It just means if it's attached to the sternum or if it's not. So true ribs are the ones that attach, and false ribs are the ones that don't attach. So true ribs are 1 to 7. As you can see here, they attach to the sternum. And the false ribs, which are from 8 to 12, they do not attach to the sternum. And when it comes to articulation, there are 3 different classifications under this category. So you have vertebrosternal. So from the name, vertebrosternal means that it articulates with the vertebra in the back and the sternum in the front. So these would be ribs 1 to 7. Vertebrochondral means they articulate with the vertebra in the back and then the costal cartilage in the front. So chondral refers to cartilage, and these are ribs 8 to 10. So you can see how ribs 8 to 10, they kind of fuse with the cartilage of rib number 7, which then attaches to the sternum. And then we have the vertebral or the floating ribs, and these are only attached to the vertebra. All right, so now let's talk about the thoracic vertebra, but before we actually get into that, let's just quickly review how to tell the difference between cervical, thoracic, and lumbar. So I'll tell you the easiest way that I used to remember when I was in first year, and it's just by looking at the spinous process. Each one of these looks like a different animal. So the cervical one kind of looks like a wolf or a dog, the thoracic looks like a giraffe, and the lumbar looks like a moose. Okay, so going into the thoracic vertebra, let's talk about it in a little bit more detail. So the thoracic vertebra has demifacets for articulation with the head of the ribs. So if you remember the structure of the rib, we had 2 facets for articulation. There was one that was more superior and there was one that was more inferior. So these are where they articulate. And then we also have the spinous process. So this is really what I use to differentiate between cervical, thoracic, and lumbar. And we also have transverse processes, and this is where there is articulation with the tubercle of the rib. And we're going to see how everything fits together here. So this is rib number 5. Notice how it articulates with the numerically corresponding vertebra, which is vertebra number 5, and also the vertebra that's above it, which is vertebra number 4. The tubercle of rib number 5 also articulates with the transverse process of vertebra number 5. Okay, so let's go back to that scenario about the car accident. So this time, imagine that the patient had broken 3 adjacent ribs, so 1, 2, and 3, and each one of those ribs was broken in 2 or more places. At which condition would they be at risk for? Okay, so flail chest. Flail chest happens when there's a double fracture of at least 3 or more adjacent ribs. And basically what this causes is paradoxical movement. Now what does that mean? Typically when you breathe in, your thoracic cavity expands, your lungs expand, and your ribs expand. But when you have flail chest, the ribs are going to move in the opposite direction. So rather than the ribs moving outwards when you breathe in, they're going to move inwards. And when you're breathing out, instead of moving inwards, they're going to move outwards. All right, so let's go through some questions now. Let's see if I can open the chart. Okay, can you guys identify these ribs? Are you guys able to see?
Yeah, it's clear.
All right, so what's this rib? I mean, this vertebra. Yes, this is cervical. And what is this one? Yes. And this one? Yes. Can you give me 2 identification points for the thoracic vertebra? Okay, so let's just go back here. Okay, so the thoracic vertebra, compared to the other 2, it has 2 demifacets for articulation, and it has the spinous process. Yes, that resembles a giraffe. Okay. So which one of these is the typical rib and which one is the atypical? Okay, so this one is atypical and this one is typical. And can you guys tell me 2 identifying features of the typical rib? Okay, so the typical rib, in the head, it would have 2 facets for articulation, and you would see a costal groove in the body or the shaft. Okay, now let's move on to external features of the heart. So imagine your heart is an orange. The pericardium would be considered the peel, or the outside covering of that orange. So you guys can see it here. Now the pericardium itself has 2 parts to it. There's a fibrous pericardium and there is a serous pericardium. So let's start off by talking about the fibrous pericardium. Fibrous, from the name, you can tell that it is made out of dense connective tissue or fibers, and this helps with its function. So the heart, when it's filling up, it tends to move outwards or bulge outwards, but because the fibrous pericardium is so dense and it's inflexible, it prevents overfilling of the heart, so it limits how much the heart can actually fill up. It also fixes the heart to the mediastinum, and this is because it attaches inferiorly to the diaphragm, anteriorly to the posterior surface of the sternum, and superiorly to the great vessels. It also has a protective function, and it protects the heart from infections. So here's just a cadaver picture of the fibrous pericardium. And let's talk about the serous pericardium. So the serous pericardium actually has 2 layers within it. You have a parietal layer, which is the outside one, and it is just behind the fibrous pericardium, and you have an inner visceral layer. So the word visceral, it just means organ. So whenever we're talking about like a pericardium or a pleura and we use the word visceral, that means that this is the layer that's directly adherent to the organ. Between the outer parietal layer and the inner visceral layer, we have a space, a fluid-filled space called the pericardial cavity. And the function of this fluid is basically for lubrication, so that when the heart expands, these 2 layers do not rub against each other. So here's a cadaver picture of the serous pericardium. You can see that we've peeled back the parietal pericardium layer, and this is the visceral epicardium. You can't peel this back because, as we mentioned before, it is directly adherent to the organ. All right, so now let's talk about the sinuses. So first of all, what is a sinus? A sinus just means a cavity or a hollow space. And the heart has two sinuses. You have a transverse pericardial sinus, and you also have an oblique sinus. So let's just start by talking about the transverse pericardial sinus. So this is located posterior to the ascending aorta and the pulmonary trunk, and anterior to the superior vena cava. So it's basically between the arteries and the veins, and it's superior to the left atrium, so it's up here. And the clinical significance of this is that it's used to identify and ligate the arteries of the heart during surgery. So for example, they're doing cardiac surgery, they would ligate these arteries. And here is just a visual representation of that. And here it shows you, here is a probe that's passing through the transverse pericardial sinus. So notice how the arteries are passing in front of it, and behind it, it would be the superior vena cava. Now, the oblique pericardial sinus is located all the way back here. It's behind the left atrium and between the aorta and the pulmonary veins. So it's formed from the reflections of the serous pericardium. So the serous pericardium actually wraps around the whole heart, but here at the area of the large veins that enter the heart, it reflects. And this is what creates the oblique pericardial sinus. And the function of this, or the clinical significance of this, is that during cardiac surgery, we go through it and we isolate the pulmonary veins. So compared to the transverse sinus, which we use to isolate the arteries, the oblique pericardial sinus is for isolating the veins. So here's just a cadaver picture. Notice how it's located all the way at the back. It's posterior to the heart and it's bounded by the IVC and the pulmonary veins. Okay, so moving on to pericarditis. Anytime you see the word itis in medicine, it just means inflammation. So pericarditis is inflammation of the pericardium. And there's a lot of things that can cause pericarditis, for example, bacterial infection, viral infection, or even a heart attack. And the patient would present with sudden onset chest pain. And a condition that this could lead to is cardiac tamponade. So this is cardiac tamponade. So do you guys remember the pericardial cavity that we talked about earlier that was between the visceral and the parietal layers of the serous pericardium? So when there is fluid buildup in that cavity, it's going to compress the heart because the fibrous pericardium on the outside is very inflexible. It won't allow the heart to expand. So now you have all of this fluid and it has nowhere to go. So it's going to push on the heart and therefore it's going to affect the heart's movement and decrease the cardiac output. The heart won't be able to fill up effectively. Now let's talk about some of the nerves. First of all is the phrenic nerve. So the word phrenic, it just means related to the diaphragm. So when you say phrenic nerve, you should know that it provides motor and sensory innervation to the diaphragm. And an easy way to remember this, along with the nerve roots, is the mnemonic C3, 4, and 5, keep the diaphragm alive. The phrenic nerve is also responsible for providing somatic innervation to the pericardium. And that's why in patients that have pericarditis, they might present to you with shoulder pain because the phrenic nerve would cause referred pain to the shoulder. So one thing that's very important to remember about the phrenic nerve is that it lies anterior to the bronchi. This is in comparison to the vagus nerve. So the vagus nerve is a cranial nerve. It's cranial nerve number 10 that comes from the brainstem, and it lies posterior to the bronchus during tracheal bifurcation. Okay, so now finally let's talk about the heart. So the heart is a muscular organ whose function is to pump blood all around the body. And it has 4 chambers, so it has the right atrium and the left atrium, and it has the ventricles, right ventricle and left ventricle. So it receives deoxygenated blood from the body through the superior vena cava and the inferior vena cava. And these drain into the right atrium. When the right atrium contracts, it's going to push the blood into the right ventricle, and the right ventricle is going to contract to push the blood into the pulmonary trunk and the pulmonary arteries. So the pulmonary trunk and the pulmonary arteries, they will carry deoxygenated blood from the right ventricle into the pulmonary circulation where they get oxygenated. After that, the blood is going to re-enter through the pulmonary veins and it will enter the left atrium. From the left atrium, it's going to contract, it'll go to the left ventricle, and then the left ventricle will contract finally, and it will push the blood into the aorta, and from there it will be distributed throughout the body. So here are just some cadaver pictures. You can see the right ventricle. The right ventricle is the most anterior heart chamber that you would see. And then next to it is the right atrium. Here you can see the pulmonary trunk that is coming out of the right ventricle, and you can see the aorta. And here is just another view showing you the superior vena cava and how it drains into the right atrium. So the heart has 4 main borders. First is the right border. So the right border is over here, and this is mostly made up by the right atrium, but also by the superior vena cava and the inferior vena cava. So they also contribute to this right border. In the inferior border, this is mostly made up of the right ventricle, but it's also contributed to by the left ventricle. And then we have the left border. So the left border is mostly by the left ventricle and some of the left atrium. And finally, the superior border up here, which is made up of the right and the left atria, as well as the great vessels. So the heart has 5 main surfaces. The first one is the anterior surface. Another name for the anterior surface is sternocostal surface. So from the name, you should be able to get that it is located directly behind the sternum. It also has a right surface and a left surface. So both of these are actually considered pulmonary surfaces because they're located next to the lungs. And it also has a base, So a base would be located behind, and the reason why it's called a base is because the heart itself, in anatomical position, it resembles a pyramid that has fallen over. So the base of that pyramid would be the posterior surface of the heart. And lastly, we have a diaphragmatic surface, which is located here at the bottom, and this is just where it rests on top of the diaphragm. So the anterior surface, or the sternocostal surface, it's mostly made up of the right ventricle. Posteriorly, or the base, because again, it resembles a pyramid that has fallen over, so the base of the pyramid would be the left atrium. Inferiorly, or the diaphragmatic surface, this would be created by the left and the right ventricles, and then the right and the left surfaces are both pulmonary surfaces, so right is made up of the right atrium, and the left is made up of the left ventricle. Now let's talk about the cardiac sulci. So the word sulcus, it just means a groove. And there are 3 cardiac sulci that we have to be aware of, and they're very easy to remember just because their names tell you exactly where they are. So the first one, the cardiac sulci, the coronary sulci, it's also known as the atrioventricular groove. So from the name, you can tell that it's between the atria and the ventricles, and it separates the atrium from the ventricles. The second one, anterior interventricular sulcus. So anterior means that it's located on the anterior surface of the heart. Interventricular meaning that it's between the ventricles and it separates them. And then posterior interventricular sulcus, it's exactly the same as the anterior one in the sense that it separates the ventricles, but it's located on the posterior surface. Okay, so this right here is the right border of the heart. Can you identify which structures make up the right border of the heart? Okay, so the right border of the heart is mostly made up of the right atrium, as well as the inferior vena cava and the superior vena cava. All right, can you identify what this is and also the clinical significance? Yes, this is the transverse sinus. Yes, exactly. And it's to ligate the pulmonary artery and the aorta during surgery. Okay, can you identify this structure and also tell me the nerve that innervates it? The structure right here. Yes, so this is the fibrous pericardium, and it is innervated by the phrenic nerve. All right, now let's move on to everybody's favorite, histology. And let's talk about the layers of the heart. So first of all, before we actually get into this, or before I explain this, I want you guys to kind of tell me what you think are the layers. So let's start with number 1. What is number 1? Yes, number 1 is the epicardium, but a little bit more, can we be a little bit more specific? Like, is it the epicardium for which chamber? Okay, so number 1 is the epicardium of the left ventricle. So let's just talk about the epicardium first. The epicardium, or first of all, the prefix epi just means over or upon. So it refers to the outermost layer of the heart. And this would be the epicardium of the left ventricle. So how can we tell that this is the left ventricle and not, for example, the right ventricle? Yes, exactly. This has a thicker wall. So the left ventricle has to generate enough force to push the blood all over the body as compared to the right ventricle, which only has to push the blood into the pulmonary circulation. So yes, number 1 is the epicardium of the left ventricle. Number 2 would be the myocardium of the left ventricle, and number 3 would be the endocardium of the left ventricle. So endo just means inside, so it's the innermost layer of the heart. And number 4 would be the lumen of the left ventricle. What would number 5 be? Okay, so number 5 is the endocardium of the interventricular septum. Why is it endocardium and not epicardium? It's because the septum is already inside the heart. The epicardium just covers it on the outside, but since the septum is already inside, it will just have endocardium. 6 is the myocardium of the septum, and 7 is the other endocardium of the septum on the other side. So 8 would be the lumen of the right ventricle, 9 is the endocardium of the right ventricle, 10 is the myocardium of the right ventricle, and 11 is the epicardium. Can anyone tell me what number 12 is? Okay, someone said apex. Are there any other answers? Okay, so number 13, it's a bit cut off actually, but number 13 would be considered the apex of the heart. Number 12 is pointing at a structure that's located inside of the heart, so inside of the heart muscles. This is the papillary muscle. And the function of the papillary muscle is basically to prevent the inversion of the valves. So specifically the mitral valve in this case, because this is the left side of the heart. Okay, so this is just the full list of everything that we just talked about. Let's move on. All right, so let's take a closer look at the myocardium, or specifically the cardiac myocytes. First of all, cardiomyocytes, they have some very unique features that you can use to distinguish between the cardiac myocytes as well as skeletal muscles and smooth muscles. So cardiac cells, they exhibit uni or binucleation. So they can either have one nucleus or two nuclei within one cell. They also tend to branch out, as you can see here, it's splitting off into two, and they have striations. So the striations are these little black lines that you can see within the cell, and this is basically just because of the sarcomeres and the bridges that are in the muscle. One thing that's very, very distinctive about cardiomyocytes are intercalated discs. So can anyone just tell me briefly what an ICD is? Okay, so an intercalated disc, that is the junction that is located between the cardiomyocytes. So it's really how the action potential can move from one cardiomyocyte to the next, and it helps the coordination of contraction of the skeletal muscle. Within the cardiac myocytes, or within the muscle tissue, you should also be able to see endomysium or connective tissue here, and you would also be able to see fibroblasts. So fibroblasts actually synthesize the endomysium. And how can you recognize the fibroblasts? They're spindle-shaped cells, and they have this flat-looking kind of nucleus. You also have capillaries. So here is a capillary that's labeled by number 6, and it has an endothelial cell. So how can you tell that this is a capillary? So typically in capillaries, you would be able to see red blood cells one at a time. It's not very apparent in this slide, but you can see the endothelial nucleus of the capillary, which is number 6. All right, so here's just another section of myocardium. So again, here we can appreciate the intercalated discs, especially. This is very, very unique to cardiac muscles. It's a very important feature. You can see the branching of the cardiac muscles. You can see the striations, which are located within the cells. And you can see uni or binucleation, as well as the endomysium or the connective tissue that's synthesized by collagen. Now let's talk about the epicardium. So this is where we are right here at the very outside of the heart. Now the pericardium, it faces the lumen of the pericardial cavity. So by the way, another name for epicardium is visceral pericardium. So the visceral pericardium that we were talking about earlier, it is also the same as the epicardium. So it faces the pericardial cavity, which is A, and this place is usually filled with pericardial serous fluid. And then you have the mesothelium. So the mesothelium is this extremely, extremely thin layer. In fact, it's only one cell thick, and it has a very flat nucleus. So this is the layer that you would see facing the lumen directly. Directly underneath the mesothelium, you would see submesothelial connective tissue, or areolar connective tissue. And areolar tissue is just a specific kind of connective tissue that tends to be looser. And then you have the adipose tissue. So one thing that's really special about the epicardium is that the adipose tissue layer tends to be quite thick. And within this layer, you can find some coronary arteries and coronary veins. And then here at E, this is where you move on to the myocardium. So let's talk a little bit about why you would see blood vessels in the epicardium. And by the way, this is a very, very important feature of the epicardium. It's because the epicardium is so far away from the lumen of the heart. That means all of the blood that's here in the lumen, it can't travel this far to supply the muscles and the tissues here. That's why it needs to receive its own blood supply through its own arteries. Okay, so here is just another section of epicardium. Again, we can see the mesothelium here. Here it's much more clear than it was in the slide before, and you can appreciate the flat nuclei of this very, very thin layer. So here again, this is the lumen of the pericardial cavity, and then you have the mesothelium, and then you have the submesothelial connective tissue, or areolar connective tissue, or the type of it specifically is areolar, and then you have the adipose tissue. Within the adipose tissue, you can see arteries and veins and nerves. So how can you tell the difference between an artery and a vein and a nerve? So arteries and veins, they tend to have a lumen. So lumen is this empty space in the middle, which is where blood passes through. While nerves don't have a lumen at all, they're just, I'm gonna try to zoom in a little bit. They're just full like this. So you guys might be thinking, okay, this is full, but this white space on the side, it indicates that this is in fact the lumen and there's just something inside. Okay, let's go a little bit deeper into the heart muscle. So this is where we are right now. And specifically, we are at the place between the endocardium and the myocardium. So this is the lumen of the ventricle. So within the lumen of the ventricle, you would find blood. This is in comparison to the epicardium, where the lumen had serous fluid, because that was the pericardial cavity. So again, similar to the mesothelium, you're going to have an endothelium that's very, very thin, one cell thick, in fact, with a very flat nucleus and a basement membrane. Directly underneath it, you're going to have subendothelial connective tissue, but the difference is this will not be areolar connective tissue. So it will be a little bit thicker. A little bit less loose. And then you're going to have the Purkinje fibers. So what are the Purkinje fibers? These are specific cells, or very specialized cells, that are responsible for generating the action potentials in the heart. So they would be right next to the cardiomyocytes, but there are certain things that you can look for to tell the difference between the Purkinje fibers and the myocytes. So it's a little bit clearer here. So these are the Purkinje cells, and these are the myocytes. So let's talk about some of the differences in them. Purkinje cells, they tend to be a lot bigger, so you can see that these are actually huge compared to these cells, and they only have one nucleus per cell, or uninucleation. The reason why it doesn't appear on all of these is probably just because of the cut of the slide, but you can see it on some cells. This is in comparison to the cardiomyocytes, which have uni or binucleation. Another thing is that the Purkinje cells tend to show up a lot paler on staining. They don't take the stain as much or as well as the myocytes do, and that's because they have a lot of glycogen in them. And another thing is that they have this haphazard organization compared to the myocytes, which are very organized and parallel. So here is a table that just summarizes the differences between them. And here is another slide. So A, these would be the Purkinje fibers. Again, they have that pale color and that distinctive big shape. And then these would be the myocytes. Okay, so how do we tell the difference between epicardium and endocardium? Because there are some similarities between the two. First of all, let's talk about the epicardium. The epicardium faces the pericardial cavity, which contains serous fluid, while the endocardium faces the lumen of the heart, which contains blood. The epicardium also has coronary vessels. So we mentioned earlier that the function of the coronary vessels is actually just to supply this area here, because since it's so far away from the lumen of the heart, it can't be supplied by the blood that's already in the heart. And they contain nerves. So nerves don't have any lumen as compared to coronary vessels, which do contain a lumen. The reason why it's full is probably because there are some RBCs in here, but you can tell that it's a lumen because there is some white space. Compared to the nerves, there is no white space. And you also have a very thick layer of adipose tissue. So this is in comparison to the endocardium. You have a thinner layer of adipose tissue. It's facing the lumen of the ventricle, so it has blood and not pericardial fluid. And you would also be able to appreciate the Purkinje fibers in the endocardium as compared to the epicardium. Okay, can you guys identify what type of tissue this is? And give me 2 identification points. Okay, someone is asking what would be the identification of Purkinje. So let's go back. These are specifically the features that you would see in the Purkinje cells. They're much larger cells. They tend to be paler, so they have very little pink compared to the cardiomyocyte, and that's because they take up the stain less intensely. They have a lot of glycogen, and they do not have intercalated discs. So intercalated discs, that's a feature that's very, very specific to cardiomyocytes. So here you can see it. Okay, so this is cardiac muscle, and some of the features that are very important for cardiac muscle and that you could see. Yes, exactly. You would see myocytes, you'd see the striations and the intercalated discs. And there's also branching. Okay, what is this? What is this a section of? And give me 2 identification points. Okay, so this is the epicardium, and we can tell that it's the epicardium because of the very thick layer of adipose tissue and the presence of coronary artery and a coronary vein. Okay, and identify these cells. So these are Purkinje cells, and we can tell because the shape, they're very big cells, they're uninucleated, and they tend to be very pale. Also, this area right here that's located between the Purkinje cells and the myocytes, this is known as the Purkinje myocyte junction. So it's just the area between them.
Okay, so now moving on to coronary vessels. So for coronary vessels, first of all, we have the aortic cusps. So the aorta has 3 cusps. It has 3 valves, and the valves are made up of cusps. So you have a right cusp, a left cusp, and a posterior cusp. Now, this is in comparison to the pulmonary valve, which has also 3 cusps. However, it has a right, a left, and an anterior cusp. So this is an important identification between each of them. You can remember this by either the fact that the aorta is behind the pulmonary trunk, so it's posterior. Or you can remember it by AP and PA. So for A, it's posterior, and for pulmonary, it's anterior. So just remember the aortic cusp has a right cusp, a left cusp, and a posterior cusp. Now, the coronary arteries, which is the main blood supply of the heart, come from these cusps. Specifically, the right cusp and the left cusp, they have something called an aortic sinus. In the aortic sinus, you have this here. It is called the coronary ostium. And this is where the coronary arteries come out of. So you have the right coronary artery coming out of the right aortic sinus, and the left coronary artery coming out of the left aortic sinus. Now that that's clear, let's look at some more pictures. So this is the aorta, and starting off with the right coronary artery, it comes off of the aorta from the right aortic sinus, and it courses anteriorly at first and through the coronary sulcus, and then it goes posteriorly to give off its branches. It gives some branches anteriorly too, which we'll see, but mostly it goes posteriorly. So now let's look at the branches of the right coronary artery. First of all, we have the SA nodal artery. So again, here's the right coronary artery. It's going to give off branches to the SA node. You don't really need to identify them, just know that it supplies the SA node, and it's only 50 to 65% of people. So it can also be supplied by the left coronary artery, which, if you want to make sense of that, both the right coronary and the left coronary are here at the top, which is the general area of the SA node. So it would be easy for the left coronary to supply a branch to the SA node and also supply it. Next, you have the right marginal artery. So when the right coronary comes off of the aorta, it courses down here, and then the branch that it gives off first anteriorly is the right marginal artery. Now, the right marginal artery supplies the right ventricle. So this is the area of the right ventricle. So this is where the right marginal artery would supply. Next, you have the AV nodal artery. Now, this, the right coronary supplies it in 80 to 90% of the time. So mostly it's from the right coronary artery. Again, this would make sense because it's closer to it. This would be the area of the AV node approximately. So the right coronary, it would be easier for it because it's down the path of the right coronary artery. It's easier for it to supply the AV node. However, the coronary artery would kind of have to take a long path to reach the AV node. So most likely the AV node is supplied by the right coronary artery. Next, you have a very important artery. It's called the posterior interventricular artery, or the posterior descending artery. Now, the name tells you exactly where it is and where you can find it. So it's posterior. So the right coronary artery courses posteriorly. You can see this like more transparent artery that's going to the back, and that is the posterior descending. So it's posterior and it's interventricular. So it's between the right and left ventricle, and it's like it goes down the interventricular sulcus. And it supplies the posterior 1/3 of the interventricular septum. And also the diaphragmatic surface of the right and left ventricle. Again, you can assume this based on the location that it's going. Now, important to note about the posterior interventricular artery, it supplies the posterior 1/3 of the interventricular septum in most people. However, in 15 to 17% of people, it's actually a branch of the left coronary artery instead of the right coronary artery. And this is determined by dominance, which we're going to talk about later. So just to summarize, this is the supply of the right coronary artery. You have most of the right atrium, the right ventricle, and the posterior 1/3 of the interventricular septum, the SA node, and the AV node. Okay, now these are just some cadaveric pictures of the right coronary artery. Over here, this is basically the same view that we're looking at here, and you can just see the artery branching off of here, and this is the right coronary artery. And then this is the posterior view. So as I told you, the right coronary artery, it's after it courses anteriorly for a bit, it's going to go posteriorly. So this is where you're going to see it coming posteriorly. It runs along here, and then it gives off PIA. This is the branch that it gives off, and it goes in the interventricular septum, and it just descends downwards. So it's the posterior interventricular artery, or the posterior descending artery. And the right coronary artery continues here, and then here is an anastomosis that I'm going to talk to you guys later when we discuss the left coronary artery. And then over here, this is just a picture from a model again. Try to identify them from as many pictures as you can, models, because you don't know what they're going to get you in the exam. So this is the posterior view of the heart. And again, you have the right coronary artery. It's the same as this picture, basically, and it's just coming posteriorly. And again, yeah, we'll talk about other parts of here later. But just know this is the right coronary artery. Now, this is a right coronary artery angiogram. So an angiogram is basically when you inject a dye into your vessels so that you can visualize the arteries. How they do this is they insert the catheter through the left femoral or the left radial artery. And from there, it goes to the brachial artery and then to the aorta and to the right and left coronary artery. Not sure if they might ask you about this, but it was in your lab material, so I just wanted to include it. So yeah, now we're looking at the right coronary artery. Now, just to get a general idea of how a right coronary artery looks on angiogram, it has an L shape. And the right coronary artery, so this is it coming off of the aorta, and this is the main branch, the right coronary artery. So it goes a long way as the main branch, and then it gives off the pia. And so you can think of the right coronary as like the length of the artery, and then pia is like the base. Sorry, not the artery, I mean the L. So this is the length of the L, and then the base of the L is made by pia. And then you have the other branches. So the SA nodal artery would be more at the top. The AV nodal artery will be branches from the bottom here. And then the right marginal coming off directly from the right coronary, the right coronary artery. I'm not sure if they'll ask you about the small branches. Focus on the main ones and try your best to identify these as well. And then this is just another view. Again, I wanted to include all the views just in case you get either or in your exam. So again, right coronary, you have the long main branch of the right coronary, and then the pia, which is the base of the L, and then you have the right marginal, you have the SA nodal artery at the top, and then AV nodal branches more at the bottom. Now we're done with the right coronary artery. By the way, I can't see the chat, so if there are any questions, please let me know. Or I have, I'm logged into my phone, so but if you text me privately, I won't see it now. I'll open it when I get to the questions. So feel free to unmute if you want. Okay, now we're moving on to the left coronary artery. So the left coronary artery, we said it comes from the left aortic sinus. So this is the left aortic sinus, and it's coming off of it. Now, important to recognize about the left coronary artery is it branches off almost immediately. Unlike the right coronary artery, which goes down its length and then starts branching, left coronary starts branching immediately. So you have the left circumflex artery coming off of here and goes posteriorly, and then you have the left anterior descending, going anteriorly. We'll discuss them more in detail now. Okay, so these are the branches of the left coronary artery and their supply. So the first branch that you have is the left anterior descending. Again, the name tells you exactly what you need to know. Left, so it comes off of the left coronary artery. Anterior, so it's anterior. And then descending, it's descending down the anterior part of the heart. Okay, so yeah, and it supplies the right and left ventricles. So again, picture just the course of it, and it will supply the right ventricle here and then the left ventricle. The right ventricle and the left ventricle. So it'll come near this area of the right and left ventricle. So it'll supply them. And the anterior 2/3 of the interventricular septum. Again, very important, because what did we say supplies the posterior 1/3? Can anyone tell me? I don't know if anyone texted me privately. Okay, so the posterior 1/3 is supplied by pia, or the posterior interventricular artery, as we said. And the anterior 2/3 is supplied by LAD. So this is very important to remember. And then this is the anastomosis that I was talking to you about. So LAD comes down here all the way to the near the apex of the heart, and it anastomoses with pia. So pia was coming here from the back, and it comes also to the apex, and then they anastomose together here. And then LAD also gives off the diagonal artery. So again, not very important to note the branch, where they are, but just know LAD gives off the diagonal branches. And then you have the left circumflex. So the left circumflex supplies the left atrium and ventricle. And it mostly goes posteriorly. So it comes off anteriorly and then it goes posteriorly, continues. And it anastomoses with the right coronary artery posteriorly. Also, I'll show you that. And it gives off a left marginal artery. Okay, so over here you can see the marginal arteries. These are coming off and back. Now let's look at the cadaveric pictures. And this is, again, same view as here. And you can see that a vessel is immediately giving off branches. So you know that this would be the left end, or the left coronary artery. And then over here, again, this is the posterior view that I showed you earlier. It's of the right coronary artery, but I wanted to show you the anastomosis with the circumflex. So the circumflex, from here, it's going to go posteriorly. And so it's going to meet, this is how it's continuing, and then it's going to meet the right coronary artery here, and they're going to anastomose. Okay. Now for the left coronary angiogram, this one, they say that it looks like a claw hand. And so you can also just remember it by that when you first look at it. At least you'll know that you're looking at a left coronary artery. So if you can identify that, then hopefully you can answer the question and decide which branch it is specifically. So as you can see again, this is the main branch of the left coronary and immediately gives off a left anterior descending. So this is going anteriorly, and you can tell because over here you can see vertebrae. So this is the posterior part. This is anterior. So you have the left anterior descending coming off of here, and it's giving off the diagonal branches, and it goes all the way down to the apex where it will anastomose, as we said. And then the left circumflex, it's going to come off of here and course a little bit anteriorly and then go to the back posteriorly. And it's going to give off its left marginal branches. Again, this is another view. Wait, yeah, okay, this is another view again. The left anterior descending going anteriorly, giving off the left diagonal branches, and then circumflex going to the back, giving off the left marginal branches. And if they point the arrow here, this is the main left coronary artery. It still hasn't branched off into anything. And this here is just the catheter. Okay, now moving on to a very, 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 very important concept, both for your MCQs and OSPE and everything, is the concept of coronary dominance. So coronary dominance basically refers to where PIA branches off of, as I said before. So PIA either comes off of the right coronary artery or it comes off of the left coronary artery. Most commonly, the right coronary artery, and it's the better scenario when it comes off of the right coronary artery. And I'll tell you why in a bit. So right dominance, as I said, is the most common. So let's look at this heart right here. This here is the interventricular septum. Now I said that the anterior 2/3 of the interventricular septum is supplied by LAD, the left anterior descending. As you can see, blue here is the left coronary artery. So the interventricular septum is supplied by the anterior 2/3 is supplied by LAD. The posterior 1/3 in right dominance is supplied by PIA, the posterior 1/3. So this is good. We have 2 blood supplies to the interventricular septum. Now let's look at in the case where we have a left dominance. So in left dominance, the anterior 2/3 of the interventricular septum is supplied by the left coronary artery, like it normally is, by LAD, just like the normal situation. The difference comes when you look at the posterior 1/3 of the interventricular septum. In this case, it's supplied also by the left coronary artery, a branch of it, the left circumflex to be specific. So the interventricular septum here is supplied completely by branches of the left coronary artery, which is very problematic. Can anyone tell me why you may think so? Why it might not be good to have the interventricular septum supplied by one artery only? Okay. So the reason this would not be so great is, I don't know if you guys can still see my screen. I had to leave. Sorry about that. Okay, so the reason that you don't want both of them to be supplied by one artery is because if you have an occlusion in the left coronary artery, then the whole interventricular septum will be infarcted, which means that it doesn't get blood supply, so it's going to die. And that's going to cause a lot more problems than if only one of the arteries was infarcted, because the other artery would still compensate in the interventricular septum. Okay, so now this is the clinical significance that I just discussed, but I wanted to use this to kind of test you guys. So in a left dominant person, PIA is a branch of what? Left dominance. Can anyone tell me? And just send it on the main chat if you can, please. Not privately. Okay, so in a left dominant person, PIA is going to be a branch of the left circumflex, which is a branch of the left coronary artery. Now, what does PIA supply? Normally, in all situations, PIA always supplies the posterior 1/3 of the interventricular septum. Okay, and what does the what supplies the anterior 2/3? Usually, the left anterior descending, which is a branch of the left coronary artery. Now, if you notice in left dominance, the problem will be that the anterior 2/3 and the posterior 1/3 will both be supplied by a branch of the left coronary artery. So that is a big problem. And the main significance of this is, as I said, if the left coronary artery is occluded for any reason, atherosclerosis or any coronary artery disease, you'll get an occlusion in the left coronary artery, and the whole interventricular septum will not have any blood supply, and it will be infarcted and die. So yeah, this is a very important concept. Please focus on it for your OSPEs and MCQs and everything. Next, let's talk about the cardiac veins. So the main venous drainage of the heart is through the coronary sinus, and which drains into the right atrium. We have three main veins that you need to know, and you need to know which artery it runs with. So you have the great cardiac vein. This is the anterior part of the heart. The great cardiac vein runs anteriorly with LAD, and then the middle cardiac vein, you can see it in the back, it runs with PIA. Very important to know which artery it runs with, because they can easily like point to it and ask you what is accompanying it. So this is the middle cardiac vein. And then the small cardiac vein runs with the right marginal artery. And all of them empty into the coronary sinus. Now the vena cordis veins or vena cordis minimus, something like that, they're just small veins that empty everywhere into all four chambers. And while it is deoxygenated blood, it's a very small amount, so it doesn't really affect the heart that much. So yeah, this is the coronary sinus. Again, this is all of the tributaries that it drains, and great middle small cardiac vein, and then you have the posterior vein of the left ventricle and the small oblique vein of the left atrium. Just know these in case they ask you like name a few tributaries of the coronary sinus. They will probably definitely ask you to identify the coronary sinus. It's very commonly asked. And then they all just drain into the right atrium. So let's get into a few questions. So can anyone identify, this is an angiogram, can anyone identify X and Y? This is Y, and then this is X. And then name two things that X supplies. So what is X? Okay, so X is LAD, the left anterior descending, and then Y is the left circumflex, because you can see that it's immediately branching, and then the one anterior is going is LAD, and then the posterior branch, or the one going more posteriorly, is the left circumflex. Name two things that X supplies. We said LAD supplies the right ventricle, the left ventricle, and it's because it's going all the way down here, so it's supplying both of them. And then it also supplies the anterior 2/3 of the interventricular septum. Okay, now name the structure and how does it develop? So this structure is the coronary sinus, and the development, I didn't explain it because it's in embryology, but they can still ask embryology questions in the OSPE, so I wanted to mention this. So the coronary sinus comes from the left common cardinal vein. So that's the development of it, and this is the coronary sinus. Okay, identify A, B, and C. Again, these are not pictures from your slides, but it's still pretty easy to identify, hopefully. This is the heart, and then, okay. So A would be the right coronary artery. It's on the right side, and it goes straight. And then you have the L, or right marginal, probably. Could be right marginal, could be PIA. Since you're seeing it anteriorly, you probably will say right marginal. And then C is LAD. So it's going anteriorly and into the, like between the ventricles. So it's LAD. Okay, now moving on to the internal features of the heart. If anyone has any questions about the previous slide, please let me know or unmute yourself and ask. Okay, so the internal features of the heart. First, let's start with the right atrium. So the right atrium is the first chamber of the heart that receives blood. And it receives blood from the SVC, IVC, and the coronary sinus, deoxygenated. And then it pumps it into the right ventricle via the tricuspid valve. Tri-right side. And then this is the right atrium. So let's look at the features of the right atrium. So first you have obviously the SVC and IVC, as we said, because it receives blood from them. So we're going to have the SVC and the IVC. And this is the valve for the IVC. It's called the Eustachian valve. And then here is the superior vena cava opening and the inferior vena cava opening. You also have the SA node is here. AV node, again, you can't really see it because it's between the between two structures, so you won't see it here. You have the tricuspid valve, you have the fossa ovalis. The fossa ovalis is this oval structure in the wall of the right atrium, and in fetal life, this was the foramen ovale. So this is the remnant of the foramen ovale, or not the remnant. The foramen ovale in fetal life is used for, if you know, shunting blood from the right side of the heart to the left side of the heart. But then when you're born, you don't need that anymore because you're gonna oxygenate blood through the lungs and it's gonna go the whole circus. So in this case, it's gonna close after birth. Because of the high oxygen concentration, it's going to close and it's gonna become the fossa ovalis. So it's an oval shape and it's very clearly identifiable and could be asked. The pectinate muscles is basically the rough edge of the right atrium. So the right atrium has a rough wall and a smooth wall. The rougher wall is called the pectinate muscle. And then it's divided, the two walls are divided by the terminal crest or the crista terminalis. And yeah. And then over here you have the coronary sinus. So the coronary sinus, and this is from your lab slides. I don't really think they're going to ask you to identify it from the cadaver. But yeah, if they do, it's in the right atrium. And this is the coronary sinus. And then the fossa ovalis, again, it's in the wall and it's an oval shaped, like indentation or something. And yeah. And then we have the pectinate muscles again. They're like more rough edges of the atrium. And then the crista terminalis, we said divides the right atrium and the left atrium. And yeah. Okay. Again, this is just another picture. I added every picture that I saw so that you guys can identify it in every picture. So whatever you get, inshallah, you'll know it. So you have the fossa ovalis, again, an oval shape. You have the interatrial septum, which is between the two atria. You have the pectinate muscles, which is the rough wall, and then the crista terminalis, dividing between the rough and the smooth wall. You have the valve of the vena cava called the Eustachian valve, as I said, and the valve of the coronary sinus is the Thebesian valve. And yeah, as I said, fossa ovalis, remnant of the foramen ovale. This can be asked in OSPE as well. Next, you have the right ventricle. So the right ventricle receives the oxygenated blood from the right atrium, and then it pumps it through the pulmonary valve, pulmonary artery to the through the pulmonary valve. So over here is the right ventricle. Okay, so for the features of the right ventricle, the very characteristic feature is the moderator band. So the moderator band, basically, it contains the bundle of His, so it's used for the electrical system of the heart. So this is how it reaches the right ventricle, through the bundle of His, and it's carried within the moderator band. Okay, and then the chordae tendineae are basically these cords in the valve. So remember, the right ventricle, you have a tricuspid valve in the right side. So you have 3 cusps, and these 3 cusps are held together by 3 papillary muscles. So you have 3 papillary muscles. You have a septal papillary muscle, which is near the septum, and then you have an anterior papillary muscle, and you have an inferior papillary muscle. So you have 3 papillary muscles that hold together. They're attached to the chordae tendineae, which are these cords that like contract and relax, or the papillary muscles contract and relax, and they basically pull the chordae tendineae. And they help to prevent prolapse of the valve when the ventricle is contracting. And then you have the trabeculae carneae. This is basically this part, which is the rough wall of the right ventricle. Next, again, you have just a cadaver picture of the moderator band. You have chordae tendineae. These are very easy to identify because, as I said, they just look like a bunch of cords. And yeah. And then in the right ventricle, you also have something called the infundibulum or the conus arteriosus. And basically, this is the smooth valve. It's like a smooth part that has the outflow part of the pulmonary artery. So this is where it's going to exit and the blood is going to be pumped out from this area, and it's called the infundibulum. And it's derived from the bulbus cordis in embryonic life. And then every other thing that we already identified, just make sure you know how to identify it in all pictures. Moderator band, chordae tendineae, papillary muscles, trabecular carne, and yeah. Next, we have the left atrium. So the left atrium, there's not really much to identify here. It receives oxygenated blood from the pulmonary veins, and then it pumps it into the left ventricle through the mitral valve. So again, mitral, two cusps. In left atrium, it would also have the valve of the foramen ovale, because we said the foramen ovale was in between, it was a shunt for between the right and left atrium. So you'll have you can see the foramen ovale here, and then you also have the left auricle, which is just another like remnant of the left atrium. Not much really to identify here, and there are other important chambers to ask about than the left atrium, to be honest. So next we have the left ventricle. And the left ventricle, this is it's a very important chamber, obviously, because it pumps blood to the whole body. And because it does that, it has a very thick wall, and this is very characteristic of the left ventricle, and it helps you identify it either through a model or a cadaver. It's very easy to identify. And yeah, it receives oxygenated blood from the left atrium and pumps it to the aorta through the aortic valve. So in the left ventricle, you have two papillary muscles because, as we said, it is a mitral valve. The mitral valve is bicuspid, so it has two cusps. So you'll have only two papillary muscles, an anterior and a posterior papillary muscle, and they're going to be attached to the chordae tendineae, and you'll also have trabecular carne. These rough edges are part of the wall. It's called the trabecular carne. And then again, you have more pictures. So you have the papillary muscles here attached to the chordae tendineae, and then the wall, these like ridges are called trabecular carne. Another picture, papillary muscle, chordae tendineae. And then again, this is just another picture of the left ventricle. You have the papillary muscles, the chordae tendineae, and then the trabecular carne, or the walls of it. And notice the thick wall of the left ventricle. Also here, you can notice that the wall is very thick. Next, we have the coronary ostium. This is what I mentioned to you guys earlier over here. It is basically where the coronary arteries flow from, like the blood from them flows through the coronary ostium. And they're just places like behind the cusps. And yeah, you can see them over here. Okay, now for the questions. So identify X and Y. Can anyone identify these? We repeated these so many times.
Is Y the papillary muscle?
Yes, exactly. Perfect. So Y is a papillary muscle. What about X?
X is the chordae tendineae.
Yep, exactly. And you know the function of the papillary muscle?
To prevent the valves to bulge out.
Yeah, so it helps to hold the valve when the ventricle is contracting. It helps to hold the valve so that it doesn't prolapse into the other chamber. And so it prevents blood from going back, basically. Okay, perfect. Okay, so label the marked structure. What is this here? Does anyone know?
Interventricular septum.
Yep, perfect. So these are the two ventricles, and this is the interventricular septum. So what are two arteries that supply it?
The pia and the lad.
Amazing. Just for bonus, which one supplies the anterior, which one supplies posterior?
Anterior is supplied by lad and the posterior is by pia.
Perfect. Thank you so much. Okay, now for visualizing the internal features of the heart by echocardiography. This is a separate lab for you guys, but I just put it here because I felt like it made more sense to link them together. So in order to visualize the internal features of the heart, or if you want to see them or diagnose any abnormalities, you will use an echocardiograph. Now you guys didn't take radiology yet, but an echocardiograph is basically an ultrasound of the heart. And what an ultrasound is it basically detects sound waves and reflects them back as an image. So the sound waves, once they hit an object, they basically reflect back or echo back to a screen and reflect an image. So think about structures that, think about different media. Let's start by air. So air, sound will travel very easily through air. In fact, very easily that it's not going to bounce back at all. It's just going to go completely through air and then dissolve there. So if you take an echocardiogram of an area that has a lot of air, it's going to be completely black because nothing is going to be reflected back. So air in an echocardiogram will be black, and we call this anechoic, or basically no echo. And then for a harder structure like a bone, if you sound waves go through bone, it's not going to be able to go through. It's going to reflect completely back. So all of this reflection is going to be completely white. And so you're just going to have white, which is called hyperechoic in echocardiography. And then the middle line would be like soft tissue structures. You'll have some that reflects back, some that doesn't. So the color will be about like grayish, and you call that hypoechoic. Okay, so again, these are not stuff that you probably will be tested on. It's just for your understanding and because it was in your lab material. But yeah, so when we visualize or when we use an echocardiograph, we're either using a transthoracic approach or a transesophageal approach. And this basically depends on where you're putting the probe. So in a transthoracic, as the name suggests, it's just over the thorax. So you can put it at the apex, you can put it below the xiphoid, depending on where in the heart you want to view, or like what view of the heart you want to see. So the transthoracic is most common and it's easiest to do because it's not invasive, as we'll see with the transesophageal. So yeah, the transesophageal, you're basically literally going as you can see here, you're going through the esophagus. And because the esophagus is directly behind the heart, this is actually a perfect view of the heart. And it's very accurate and it's very sensitive for diagnosing valvular abnormalities. It's very good if you have a very high indication to do the transesophageal echo. But if you just want to see the heart, if you just want to like visualize it initially, you will most likely use a transthoracic approach. And that's the one that you guys did in lab as well. So this is the ultrasound that you have in the lab. I put a star here because this is very important and you will 100% have this question. Because it's only one thing that you have to identify in this lab. So it always comes. So basically in the echocardiograph, when you look at the chambers of the heart, they'll be flipped. So at the bottom, you'll have the atrium and the top, you'll have the ventricles. And obviously right and left is flipped, just like any other case. So you have the left atrium at the bottom and then the left ventricle. Between them is this thing here, it's the mitral valve. And then the right atrium and the right ventricle here. Between them is the tricuspid valve. So this is a transthoracic view, transthoracic approach, and an apical view of the heart. So you're looking at it from the apex. Okay, so now I'll test you guys. So what is X? Okay, so we said that these are the atria. And then these are the ventricles. This is the right side, this is the left side. So between the right, or sorry, this is the left side, and then this is the right side. So you have, in the left side, you have the mitral valve. So X is between the left ventricle and left atrium, so it's the mitral valve. What sound does this make? Is the first heart sound, which is LUB, or S1. Okay, now moving on to the histology of vessels and microcirculation. Sorry. Okay, so for the histology, we're going to be describing all of the vessels, starting from the arteries and then to smaller ones like muscular artery, arterials, and then we're gonna go to capillaries, venules. So we're basically going to be going through the whole pathway of blood. And the reason I put these slides was just to show you that we're going basically from closest to the heart to further. So the elastic artery, or the first artery that we're going to see, it's closest to the heart. And then as you go down, they're further and further and further from the heart. And the further from the heart they are, the smaller that they are, and the more in number that they are. So, as a general overview of arteries, we have the tunica intima, the tunica media, and the tunica externa. The tunica intima is the innermost layer of the vessel, so it's closest to the lumen. And this is where you have the endothelium, which is a simple squamous epithelium. And you also have subendothelial connective tissue. And then you have internal elastic lamina. Now, this won't be found in all vessels, but if you do find an internal elastic lamina, then you know that's in the tunica intima. So remember, I for internal for intima. Internal elastic for intima. The internal elastic lamina, and it's fenestrated, which means it has pores. And then you have the tunica media. Remember, media, M for muscles. So the tunica media, this has smooth muscle cells and elastic and collagen fibers. And we also have external elastic lamina. So in the intima, we had internal elastic lamina. In the media, we have external elastic lamina. Remember, these won't be seen in every vessel that you see, but if you see it, you know that it's in the media. And then we have the tunica externa, which is the outermost layer. Let's start with the elastic artery. So the elastic artery is the aorta. So the aorta has a lot of elastic fibers because it needs to recoil and coil and recoil basically as the left ventricle is contracting when it has to push blood to the rest of the body. So you will see a lot of elastic fibers, which is why it's called the elastic artery. And an example of it is the aorta. You really need to remember the name of the artery, the functional name of the artery, an example of it, and then even the analogous veins. They can ask you any of these when you're identifying. So you have the elastic artery. This is, again, very characteristic because you can see elastic fibers. The tunica intima has endothelium connective tissue. And then the tunica media, you will have external elastic lamina. As I said, the external is usually in the media. It's always in the media, and it's fenestrated. So you have 40 to 70 layers of external elastic lamina. And then you also have 30 to 40 circular smooth muscle layers. Now, focus on this as well, because as you go like further from the heart, you'll have less smooth muscle layers, which makes sense because you'll be pumping blood from when you're closest to the heart, you're pumping blood from a very long distance. As you get farther from the heart, you're kind of getting closer to the areas where you want to pump blood, so you won't have to push as strongly. So you don't have that many smooth muscles as you go further. But the elastic artery or the aorta has the most layers of smooth muscles. And then you also have collagen. And in the adventitia, we have fibroblasts and macrophages. Again, function, expanding and recoiling, and analogous veins are SBC and IBC. Now let's move on to the muscular artery. So the muscular artery, it is also known as the distributing artery, and an example of it is the ulnar artery. The muscular artery is very prominent as well, and it's very characteristic because it has two elastic lamina. It has an internal and an external. So you can see it here very clearly. This is the internal elastic lamina, and this is the external elastic lamina. The internal elastic lamina is in the tunica intima, and the external is in the tunica media, between the media and the externa. So yeah, you really have to identify these two. So yeah, in the tunica intima, we have internal elastic lamina. Tunica media, we have external elastic lamina, and we have 20 smooth muscle layers. So here we had 30 to 40. Here we have 20. Here we had an external elastic lamina in the tunica media. Here we have an internal and an external. And then the tunica externa, we have fibroblasts and macrophages, analogous veins, ulnar veins. Okay, now for the small muscular artery. So an example of it is the digital arteries, and an analogous vein is the digital veins. This one only has an internal elastic lamina. So elastic artery only had an external. Remember E for E. Elastic only had external. Muscular has internal and external. And then small muscular only has an internal elastic lamina in the tunica intima. Okay, and it's fenestrated. And then you have the tunica media has less smooth muscles. It has 10. So this is the tunica media. Again, here you had 20, now you have 10. And then the tunica externa, we have fibroblasts in collagen. And yeah, analogous veins, digital veins. Now we have the arterial. This is very, very, very important, very high yield, and you need to know everything about this. The name of it, arterial. The functional name, resistance vessel, also very important to know. And the function of it is to control blood pressure. So because of that, it's called the resistance vessel. So it controls blood pressure and it's called the arterial. Okay, let's look at the functions or the structure. And by the way, it does not have any elastic lamina. So again, that's a difference from all the other ones. So the tunica intima of it has the endothelium and connective tissue. Important here is the shape of the endothelium, or the nature of it is bulging and round. So you can see the endothelium here is round and bulging. And why is this? It's because of vasoconstriction, because we said it controls blood pressure. So it's because of the vasoconstriction, the endothelium bulges. And here again, you can see the bulging endothelium. The tunica media has 1 to 2 layers of smooth muscles. It's not much at all, as you can see here in the electron microscopy. Not many layers of smooth muscles. Again, here you can also see the smooth muscles in the light microscope. And then the tunica externa has thin collagen. And yeah, function and the vein. So this is just a summary. Now, obviously, we explained everything separately, but do note that, again, this is all continuous with each other. So you have the large artery, and then the middle muscular artery, and then the smaller muscular artery, and then arterial. You can go over these as a review. Okay, so question time. Name the artery.
Is
Anyone?
it the elastic artery?
Yes, exactly. What's an example of it?
Aorta?
Yes, aorta. And you can tell by all the elastic fibers. Oh, I just gave away the second question. Okay. What's the main identifying feature of this artery? You have elastic fibers. What else can you say about it? Not necessarily here, just in an elastic artery in general. What do you have?
A lot of elastic laminae?
Yeah, you have elastic lamina. You have, is it external or internal? Elastic lamina.
External?
Sorry?
External?
Yeah, external. Remember, elastic for external. So the external would be in the tunica media. Okay, so yeah, very good. Thank you. What about here? What is seen here?
It's an arterial?
Yes, perfect. How did you know that? What's very
Um,
characteristic in this?
Because very less smooth muscles and the bulging endothelium.
Perfect. And why is the endothelium bulging?
Because of the vasoconstriction that it does.
Yes, perfect. Thank you so much. Okay. Sorry.
Assalamu alaikum. Can you guys see my screen?
Yes.
Yes.
All right. Okay, so now we're going to talk about large veins. Just a second. Okay, so large veins have 3 layers. You have a tunica intima, a tunica media, and a tunica externa. So tunica intima, I for intima, and I for inside. This is the innermost layer of the large vein, and it consists of endothelium and fibroblasts. So that would be located right over here. The tunica media, so M for middle, and also M for muscle because it contains circular smooth muscles, and it contains collagen. So one thing that's very particular about the tunica media in large veins, especially compared to arterioles, is that the tunica media layer tends to be very, very thin. The next layer is the tunica externa. So this is actually the thickest layer in the large veins, and it is made up of thick longitudinal smooth muscles, which we will see in the next slide, as well as collagen fibers. So here is what it looks like up close. So these are the smooth muscles and these are the collagen fibers. So notice that the collagen fibers take up the stain a little bit more brightly as compared to the smooth muscles. So now let's look at skeletal muscle, and we're specifically going to be looking at the tongue. So here is just a zoomed in picture of the skeletal muscle at the tongue. And let's look at some of the features. So skeletal muscle cells tend to be lined up in parallel. So this was also a feature that we saw in the cardiomyocytes. They also have these capillaries, and these capillaries are made up of endothelial cells. So you have these endothelial cells, and the way that you can identify them is that they have a very, very flat nucleus. So endothelial cells are simple squamous cells with a flat nucleus. And you have these red blood cells, and the way that you can identify that this is a capillary is you look at the RBCs and the way that they're lined up. So since capillaries are very, very small, RBCs can only fit in there one at a time, so they're lined up in a row. Another thing that you could see here is collagen, and this collagen would be synthesized by fibroblasts, which you can see here as cell number 4. All right, so we're still in the skeletal muscle, but let's take a look at the arterioles and the venules. So you can see these in skeletal muscle. Can anyone tell me how we can differentiate between them?
Can you
Okay, so
repeat your question, please?
can you tell me how we differentiate between the arterioles and the venules? Okay, so arterioles tend to have a thicker muscle layer as compared to venules. And you can also look at the lumen. So the lumen of the arterioles tends to be more narrow and more circular shaped as compared to the venules, which is wide. And this is just because one of the functions of the arterioles is to help maintain the pressure of the blood. So it needs that thicker muscular layer, and it also needs that lumen. Whereas for venules, the pressure is not very high, and that's why it has a thinner layer. All right, so now we're going to be looking at the pigmented skin. So we're specifically going to be here in this place, right underneath the epidermis and just above the dermis. So the epidermis itself, this is a layer that is avascular. It does not contain any blood vessels. So that's why the blood vessels that are located here in the upper part of the dermis, they actually keep the epidermis alive. So let's take a look. Here in the slide, we can see the lymphatic and the blood capillaries. So how can we tell this is a blood capillary? Again, because of the RBCs, they're lined up one at a time, and you can see the endothelial cells with their flat nuclei. You can also see smooth muscle cells here, and you can see collagen, which is synthesized by fibroblasts. There will also be adipocytes here, but I don't think you can appreciate them very well in this slide. And you also see these lymphatic capillaries. So as for these lymphatic capillaries, they didn't talk about them much in your lab files, but just to briefly go over them, they are similar to veins in the sense that they have a very thin muscle layer, and they have this one cell thick endothelium, and the lumen is irregular. Okay, so now we're going to talk about the U-turn concept. So the U-turn concept that Dr. Annie talks about is how the arterioles, they branch into capillaries, and then the capillaries merge and they form venules. And here in this layer, especially directly underneath the epidermis, you wouldn't really see arterioles and venules. You would mostly see capillaries. So the arterioles and the venules, those are a little bit bigger. You would see them below. So this right here is just the transverse section of a capillary, and you can see how it's very small, and it just has that endothelial cell, which you can tell by that flat nucleus. So here is another transverse section of a capillary, the flat nucleus of the endothelial cell, and you can see that there's one erythrocyte or one RBC located inside. So this is the same as before, just the transverse cut of the capillary with the flat nucleus of the endothelium. All right, so now that we're located a little bit deeper into the dermis, we're actually able to see the arterioles and the venules. Because remember, the arterioles and the arterioles specifically, they branch out to form capillaries, and you would find the capillaries up here, and then the capillaries would merge, and then they would form venules. So these are analogous, venules and arterioles, and again, you can tell the difference between them because the arteriole has that thicker muscle layer as compared to the venule, and it has a more circular lumen as compared to the venule, which is a little bit more irregular. Right, and this is just a slide that shows you arterioles, venules, and lymphatic capillaries. So again, this is a little bit deeper into the dermis, it's not up here. And the arterioles that branch out here and they make capillaries, those capillaries are responsible for keeping the avascular epidermis alive. Now let's take a look at some electron microscopy images. By the way, electron microscopy is very, very, very important for your OSPE. So let's start off with the endothelial cell. The endothelial cell has two main identification points that you can see here. The first one is this pinocytic vesicle. Do you see it here? It's labeled with V. These vesicles are basically responsible for transporting molecules within the cell and throughout the cell. So these are for molecules that are a little bit too big to travel through simple diffusion. They go through these vesicles. The other thing that you can see is these Weibel pallid bodies, and the function of them is basically storage granules. All right, now let's take a look at the arterial. So Shahad already talked about this in details, and I just want to reiterate what she said, that these are very, very important for your OSPE. And I'm going to be focused a little bit more on the electron microscopy image. So there are two main identification points for the arteriole. The first one is that there is no fenestrated elastic lamina. So a fenestrate is basically a gap or an area where there is thinning of the cytoplasm, and we're going to see that a little bit later in some of the capillaries, but it's important to note that you do not see it in arterioles. And the other main identification point is that you have one layer of circular smooth muscle that surrounds the entire arteriole. And this smooth muscle is very important because it helps with vasoconstriction and controlling blood flow. All right, now let's talk about the capillaries. So there are three capillaries that we're going to talk about. The first one is the continuous capillary. So the continuous capillary, this one you can find it pretty much all over the body, especially in the brain. It makes up the blood-brain barrier. And the difference between this capillary and the other two ones that we're going to talk about is the continuous capillary it tends to not leak. And that's because of a few important features that we're going to talk about. So the first one is the endothelial cells, the fact that they are continuous, so there are no gaps in between them that can allow for anything to get out. The second one is these parasites. So parasites are supportive cells that kind of hug the endothelium, and they also help in preventing things from leaking out of the capillary. Continuous capillaries also show something called marginal folds. So marginal folds, these are just cytoplasmic folds, and these are another identification point for continuous capillaries. And the function of them is the simple diffusion of small molecules, because it doesn't leak, so it doesn't allow big molecules to come out. So this is just a scanning electron microscopy image of the parasite to show you what it looks like on the outside of the capillary. So you see how it has these processes that hug the capillary. So this helps with vascular support and stability. And there are some other important functions of the cell. It is a stem cell, so it can actually produce or differentiate into endothelial and smooth muscle cells. They are contractile cells, so they can help modify the blood flow. So if they contract, they reduce the blood flow, and if they relax, they allow the blood flow to increase. They contribute to the blood-brain barrier, which, if you're unfamiliar with this, the blood-brain barrier is basically the barrier in your brain between the blood and the brain tissue. And it's very, very important that it does not leak at all. So it's very important to have capillaries that don't leak in the blood, in the brain. It also helps with angiogenesis. So angiogenesis is just the formation of new blood vessels and wound healing. And you would typically find these within the basement membrane of the endothelium, where you would normally see a tunica media in continuous capillaries. Okay, so moving on to the second type of capillary, which is the fenestrated capillary. So the main thing about fenestrated capillaries from the name is that they have fenestrae. So fenestrae are these gaps, and they're areas where you basically have thinning of the cytoplasm. And the way that this affects the function is that it allows some of the bigger molecules to come out, so it's a little bit more leaky as compared to the continuous ones, and it also allows the transport of macromolecules by pinocytic vesicles. So yeah, the two main things that we're going to look for are the fenestrae right here, which are these gaps, and also the cytoplasm of the endothelial cell, which is a little bit thinner. And the very last type of capillary is the sinusoid. So the sinusoid is the leakiest type of capillary, and that's because it has large fenestrae and it has a discontinuous basement membrane. So it allows for the transport of large proteins. They can easily leave the cell, the endothelium, the capillary. And the location of these, you would typically see these in the liver, the spleen, the bone marrow, and the lymphoid organs. So the main identification points for these are, again, you have the large fenestrae and also the discontinuous or incomplete basement membrane. And here is just a scanning electron microscopy image of the fenestrated capillary. So this is what it looks like from the outside. Can you appreciate these really large fenestrae, these gaps that would allow large proteins to leave? Okay, now I want to ask you guys, can you tell me what type of capillary this is? If you guys want to unmute, you can go ahead and do that.
It's the continuous capillary.
Yes, exactly. And can you tell me 2 identification points for it?
No fenestrations and I don't know the second one, honestly.
Yeah, so you're right. No fenestrations. It has a continuous basement membrane, and it's the presence of these parasites, so these supportive cells that hug it from the outside. And it also contains these marginal folds, which are just folds of cytoplasm. All right, can you identify which cell this is, or what this picture is showing? Okay, so this is an endothelial cell, and you can tell that it is one because it has these pinocytic vesicles and these wavopallid bodies, and this is where it would be located in the capillary, is the flat nucleus of it. All right, can you identify which type of capillary this is?
Sinusoidal capillary.
Yes, exactly. So can you tell me 2 identification points of it?
The smaller lumen and a lot of fenestrations.
Yeah, so it has large fenestrations and the discontinuous basement membrane. All right, which one of these is the resistance vessel?
A.
Yes, exactly. So A is the arterial, or the resistance vessel. All right, can you identify what this slide shows?
Is it a skeletal muscle?
Yes, exactly. So this is the skeletal muscle. You can see the parallel fibers. You can see the capillaries, the capillary with the endothelium and the red blood cells, and you can also see the fibroblast and the collagen. All right, now let's move on to the mediastinum. So the mediastinum is a 3D space that is located in your thoracic cavity. Anteriorly, it is bound by the sternum. Posteriorly, it is bound by the vertebral collar. Superiorly, which you can't see in this image, it would be the superior thoracic aperture up here, and inferiorly, it would be the diaphragm. On both sides, you have the mediastinal pleura, which we're going to talk about in more details when we actually talk about the pleura. But for now, just to give you an idea of what it is, it's just the covering. The pleura is like this covering around the lungs, and the mediastinal pleura is the one that faces the mediastinum. So as we go through these next slides, we're going to be looking at 2D images, but one thing I want you guys to keep in mind is that the mediastinum is a 3D space, so try to imagine how everything is going to be fitting together. All right, so let's talk about the boundaries. So first of all, the mediastinum can be divided into superior and inferior by an imaginary line. So this imaginary line would run from the sternal angle, which we talked about earlier, all the way to the T4 vertebra. Anything above this line would be considered superior mediastinum, and anything below this line would be considered inferior. And when it comes to inferior, you can further divide that into anterior mediastinum, middle mediastinum, and posterior mediastinum. So let's talk a little bit about the superior mediastinum. So superiorly, it is going to be bound, or the superior border of it is the thoracic inlet, or the superior thoracic aperture. Inferiorly, it would just be continuous with the inferior mediastinum because it's right on top of it at the level of the sternal angle. Anteriorly, you would have the manubrium of the sternum, so try to imagine the manubrium of the sternum here. Posteriorly, you would have the vertebral bodies of T1, T2, T3, and T4, because anything below T4 is considered inferior mediastinum. And laterally, on both sides, you would have the pleura of the lungs. So let's talk about the contents of the superior mediastinum. So the superior mediastinum, it has the great vessels, so that includes the arch of the aorta, the pulmonary trunk, the pulmonary vessels, as well as the superior vena cava and the veins that make it up. You would also see the vagus and the phrenic nerves. You would see the thoracic duct, the trachea, and directly behind the trachea, you would see the esophagus. In infants, you would be able to see a thymus, but since as you grow older, the thymus regresses, so in adults, you wouldn't see it, or you would just see a remnant of it. and also the sympathetic trunk, which is just a bundle of sympathetic fibers. Okay, so now we're going to be looking at some CT scans, but before we do, let's just make sure that we all know how we're supposed to be looking at these scans. So always, always, always imagine that the patient is sitting in front of you with their feet facing towards you and their head away from you. So that means that your right is going to be the opposite of their right, and your left is going to be the opposite of their left. And anything anteriorly in the patient's body we would see as up, and anything posteriorly we would see as down. So we're actually going to keep coming back to this image so we can recognize exactly which levels we are when we're doing the CT scans. So this is the first scan, and one thing you should note is that air on a CT scan appears black, bones appear white, blood vessels, or the blood in the vessels, when you have contrast, they appear white, and muscles and fat appear gray. So we're going to be looking at 4 different levels, but I just want to clarify that these are just 4 levels. They're not specifically T1, T2, T3, T4. These are just different levels that we're going to be looking at. And you won't even be asked, or I don't think you'll be asked about which levels they would be. They might just ask you to identify the specific structures. So let's start with the first level, and the very first thing that you can notice is the trachea. So the trachea has a very distinctive C-shaped, and that's because it has a C-shaped cartilage, and in the back here it has the trachealis muscle. And you can see, and you can definitely tell that it's the trachea because it's black, because it's full of air. Directly behind the trachea, you have the esophagus. Now, talking about the blood vessels, the first one that we can see here, number 1, this is the left brachiocephalic vein. Now, the reason why it has this oval shape is because the left brachiocephalic vein actually crosses over from the left side to go to the right side. And in the right side, that is when it meets up with the right brachiocephalic vein. Together, they drain into the superior vena cava and they form the superior vena cava. The other arteries that we should appreciate are the brachiocephalic artery, which is number 3, and the left common carotid and the left subclavian. So does anybody know why we have left common carotid and left subclavian, but we don't have right common carotid and right subclavian at this level? We can take a look here. So the right common carotid and the right subclavian arteries, they actually form at a level that's higher than the left common carotid and the left subclavian. And that's because they emerge out of the brachiocephalic trunk and not directly from the arch of the aorta, like the vessels on the left do. So for this CT scan, we would be somewhere around here. We're seeing the left brachiocephalic vein, we're seeing the right brachiocephalic vein, and we're seeing the brachiocephalic trunk, as well as the left common carotid and the left subclavian. So one thing to note about the left common carotid and the left subclavian is that the left common carotid tends to be a little bit more anterior as compared to the left subclavian. All right, now let's move on to the second level. And in this level, the first thing, of course, you're going to notice is the trachea. Again, we still have the trachea. It's black because it's full of air, and it has that distinctive C shape because of the cartilage rings. Directly behind the trachea is the esophagus. Now here, we can see the arch of the aorta. So the arch of the aorta has a very, very distinctive shape, and that is because it crosses over. It crosses over, and it goes from anterior to posterior. The other vessels that we can appreciate here are the superior vena cava and the azygos vein. So specifically for the superior vena cava, we have now reached at a level where the left brachiocephalic and the right brachiocephalic have joined to form. So we would be somewhere around here. We can see the arch of the aorta, and we see the superior vena cava as well as the azygos vein. Is this clear? Guys, if you have any questions, please feel free to stop me. Okay, now let's move on to the third level. Okay, so this is where it starts to get a little bit more complex because there are more arteries and structures that we have to identify, but if you know exactly what to look for, it'll be easy. So first thing, right off the bat, you can notice that there is no more trachea. Instead, you have the left bronchus and you have the right bronchus. So what does this mean? That means that we have officially passed the level after the tracheal bifurcation, which typically happens at T4 or T5. So again, we can appreciate the esophagus, but in the space where it was before. So previously it was directly behind the trachea, and now it's behind the bronchi. And then we can also appreciate the azygous vein. So previously here, the azygous vein was to the right of the trachea, but now it's more of a posterior structure and it's behind the bronchi, as well as behind the esophagus. And here we have gone down past the arch of the aorta. So we can recognize the ascending aorta as well as the descending aorta. So this is the ascending aorta and this is the descending aorta. And if we were to go just a little bit up, we would see that it would arch over like this. Number 3 is the pulmonary trunk. So the pulmonary trunk, this is coming directly out of the right ventricle and it branches to give you the pulmonary arteries. For example, number 8, this right here is the left pulmonary artery that's coming directly out of the pulmonary trunk. Number 9 is the superior vena cava. It's still in the same position as it was before. So for this cross-section specifically, we would be located somewhere here. Because we are seeing both parts of the aorta. We're seeing some of the pulmonary trunk and one of the pulmonary arteries. And finally, the last level, level 4. And in this level, we can see all of the chambers of the heart. So let's start off with the most anterior chamber, which, as we mentioned before, is the right ventricle. So the right ventricle, and between the right ventricle and the right atrium, you're going to have the tricuspid valve. So it'll be right ventricle, tricuspid valve, right atrium. And it will be the same exact thing here, only the left side of the heart. So number 4 is the left ventricle, number 5 is the left atrium, and between them, you would have the mitral valve. So you can see a blood vessel that's draining directly into the left atrium. Which blood vessel do you think it would be that drains directly into the left atrium? Okay, it's the pulmonary vein. This is specifically the right pulmonary vein. And here we can still see the esophagus. It's located posteriorly. We see the azygous vein, which is behind the esophagus, and we can see the descending aorta. Okay, so this is another cross-section of the superior mediastinum. So we're going to be looking at the same structures that we looked at before, but here it's just going to be a little bit more colorful. So let's start with number 1, the left brachiocephalic vein. And again, it has this distinctive shape because it crosses over from the left to the right. Number 2 is the right brachiocephalic vein. So together they join and they form the superior vena cava at a level below this one. So this is before they join this level. The next artery that we're going to be looking at is the brachiocephalic trunk. So the brachiocephalic trunk, compared to the other arteries, it's going to be a little bit more towards the center and a little bit more towards the right. This is in comparison with the left common carotid and the left subclavian artery, because these arteries are on the left side. So number 4 is the left common carotid. As we mentioned earlier, the left common carotid tends to be a little bit more anterior as compared to the left subclavian. And number 6 here, we can see the esophagus, and the esophagus is always directly behind the trachea. So number 7 is the trachea, and it has that distinctive C shape, and it is black and full of air, and it's empty here. And then here we are also able to appreciate some of the bony structures. So number 8 shows the clavicle. Number 9 is the sternoclavicular joint. So this is the joint that's located between the clavicle and the sternum. So that means number 10 here is the sternum. All right. And again, here is just another cross-section of the superior mediastinum. So again, you can see the left brachiocephalic vein, the right brachiocephalic vein. You can see the trachea, the esophagus, the brachiocephalic trunk, the left common carotid, left subclavian, and here again, you can appreciate the bony structures. So you should be able to see the sternoclavicular joint, which is I. H would be the manubrium of the sternum, and J is the clavicle itself. Okay, now let's talk about Horner's syndrome. So Horner's syndrome is when you have a cancer of the lung. It's also called Pancoast syndrome. And this cancer would be located towards the back and it would compress the sympathetic trunk. So just as a quick revision, the sympathetic nervous system is responsible for fight and flight. So when you have this tumor that compresses the sympathetic trunk, you are going to be affecting those functions. And this is going to manifest in the form of ptosis, meiosis, and anhidrosis. So the patient would come to you with ptosis, which is just drooping of the eyelid. They would come to you with meiosis, which is constriction of the pupil. And they would also have anhidrosis. So anhidrosis means that they would not be sweating from that side of the face. It would just appear dry. All right, so these are just some cadaver pictures of the mediastinum, and we can just go through some of the structures. So again, we have the arch of the aorta. We can appreciate the brachiocephalic trunk, which goes up to the right and eventually branches off into the right subclavian and right common carotid. And then we also have the left common carotid and the left subclavian, which come directly out. We have the right and the left vagus nerves. We also have the phrenic nerves and the recurrent laryngeal nerves. And this picture is just showing the same things in a different view. All right, and again, this is a picture, but here you can see the posterior structures of the mediastinum a little bit better. So here we have the thymic fat. The thymic fat, this is just a remnant of the thymus. You typically will not see a thymus in an adult, as we mentioned earlier, but you could see it in a baby. You have the arch of the aorta, the intercostal muscles, and here at the very, very back, we can appreciate the intercostal veins and arteries and nerves. So just a good mnemonic to remember the order of the intercostal vein, artery, nerve, the neurovascular bundle is just VAN. So V for vein, A for artery, N for nerve. And here you can see the arch of the azygous vein as well as the thoracic aorta. So the thoracic aorta is the part of the aorta that comes just after the descending aorta. So it's the part of the aorta that runs through the thorax. And you can also see the sympathetic trunk. So this is what gets compressed in Horner's syndrome. And here is just another view. Here you can also appreciate the azygous vein a little bit better and the thoracic duct. So if you ever get confused about the azygous vein and the thoracic duct, you get confused between them, just notice that the azygous vein receives tributaries from all of these intercostal veins, and they all meet up and they drain here, while the thoracic duct does not, and the thoracic duct also tends to be more of a pale structure. Okay, so can someone just identify what structures are number 10 and number 5?
10 is the right pulmonary vein.
Exactly. And number 5 is?
I'm not sure, but is it the left atrium?
Yes, exactly. So the right pulmonary vein drains into the left atrium, and then from the left atrium it goes to the left ventricle, and then it's going to be pumped all around the body. All right, can someone identify structure B and structure D?
B is the trachea, and D is the left common carotid.
Yes, exactly. So D is the left common carotid. It's a little bit more anterior than the left subclavian, which would be C. All right, and this one is pretty easy. Can someone just identify 2?
Arch of the aorta.
Yes, exactly. Okay, so let's do a 10-minute break. Is 10 minutes okay? Or would you guys prefer a longer or a shorter one?
No, it's okay.
Okay, so now let's continue. We have the intercostal space and diaphragm. So for the intercostal space lab, this I don't really think it's that high yield to identify things, at least for your OSPE. It might be more useful for your MCQs, but inshallah we'll go over everything that they might ask about. So for the content of the intercostal space, we have the neurovascular bundle, which is the vein, artery, and the nerve. And this is from superior to inferior, as you can see here. And they run in the costal groove, as Safia showed you guys in the very beginning. The costal groove is like an inferior part of the rib, and it has the neurovascular bundle. And it's between the internal and innermost intercostal muscles. Again, I'll show you that when we talk about the muscles. So intercostal muscles, we have 3 layers. We have the external, and then we have the internal, and then we have the innermost. Obviously, from external to internal, this is what they're called. And they all have muscle fibers going in different directions. And this just ensures that you're covering your, you have the most range of motion with these muscles and the most support as possible. So the external muscles, you'll see that they are, their fibers are going inward like this. Usually they tell you to imagine like you're putting your hands in your pockets. So this is how the fibers are oriented. And then for the internal and innermost, they're the opposite way. So this here is the external intercostal, and then you have the internal intercostal and the innermost intercostal. And you can see here what I mentioned earlier, that the neurovascular bundle here is between the innermost intercostal and the internal intercostal. Okay, now let's look at the individual muscles. So we have, we said we have the external intercostal. So for this one, I want you to picture the intercostal muscle starting, the intercostal muscle starting posteriorly. So over here, this green muscle thing, this the one I highlighted green, it starts from here. So it starts posteriorly and then goes anteriorly. So as it starts to end anteriorly, it's going to be replaced by a membrane. It's not going to continue as a muscle anteriorly. It just starts as a muscle and then it becomes replaced by a membrane, which is called the anterior intercostal membrane. For the internal intercostal or the middle layer, it starts the opposite. It starts anteriorly with the muscle, and then it goes all the way to the back. And then as it ends posteriorly, it gets replaced by a membrane, which is called the posterior intercostal membrane. Okay? That's it for these two. For the innermost intercostal, this one has muscles on all sides. It doesn't have a membrane. And you can think of this like, since it's the innermost, it's closer to your internal structures, your organs and everything. So you need the most protection in the innermost part. So you have muscles on all directions. You have anterior muscles, lateral and posterior. So your anterior muscles are called the transversus thoracis, and it's attached to the sternum. And then laterally, you have the intercostalis intimus. And then posteriorly, you have the subcostalis. And here you can just take another look at them. So attached to the sternum, you'll have the transversus thoracis, it's coming anteriorly. And then posteriorly, you have the subcostalis. Okay, now for the neurovascular bundle, or the drainage of the intercostal spaces, basically, the venous drainage of them is through, we have anterior and posterior drainage. The posterior drainage is going to be from the azygos and the hemiazygos. Now, again, you should remember this because we repeated it many times, that these veins are posterior. They're in the posterior wall. So it makes sense for them to innervate the posterior intercostals. Okay, so not innervates, sorry, drain, venous drainage. So the azygos drains the right posterior intercostal, and it drains into the superior vena cava. Hemiazygos for the left side, and it drains into the azygos, which ultimately drains into the vena cava. This is posterior. For anterior, we have the internal thoracic or musculophrenic, and they drain into the internal jugular and subclavian, and then the right and left brachiocephalic, and finally to the superior vena cava. Okay, so let's look at them. Again, this is the vertebrae, so you know that this is the posterior part. On the right side, you have the azygos and the hemiazygos draining into the azygos, and then together they drain into the superior vena cava. Over here, you can also see them. You can see the azygos, hemiazygos coming into it, and then they go and drain into the SVC. Anteriorly, we said we have the internal thoracic veins. So these are the veins going anteriorly, and then they drain into the internal jugular and left subclavian or subclavian, and then into the right and left brachiocephalic, and then to the SVC. Again, I don't really think these are like they're going to point to something very specific and let you identify it. But you can tell that since these are anterior, they should be the internal thoracic veins. And then the posterior ones, definitely you have to identify the azygos and hemiazygos. These are very important. But for the very small details, inshallah, I don't think it should be asked in OSPE, but know what you can from it. Next, we have the arteries. So for the arteries, again, we have a posterior and an anterior supply. For the anterior supply, this is basically just a summary I had from first year. I don't know if it helps, but this is how I had to picture it in my head. So for the anterior supply, it's mostly by the internal thoracic artery. This is for anterior. The posterior, mainly by the thoracic aorta. If you remember these two general things, that should be like a good starting point. And then we can go further from that. So again, anterior here, we have the internal thoracic arteries and anteriorly. And even if you look at this rib here, you can see that anteriorly you have the internal thoracic arteries, and it's giving branches to the rib. So it's supplying the intercostal space. And then the posterior, we have the thoracic artery, and that is giving the arterial supply to the posterior intercostal spaces. So yeah, what they said is anteriorly, you have the subclavian, basically. The blood supply is from the subclavian, which gives you the internal thoracic. So internal thoracic is a branch of the subclavian. So the blood supply is from the subclavian and the internal thoracic, and then to the musculophrenic. In your lab, they mentioned this all as one. I think this is from the lecture where it was separate, but in your lab, it's just subclavian, internal thoracic, musculophrenic is the anterior wall blood supply. Posteriorly, we have first, oh, by the way, the last two intercostal spaces in the anterior, they don't have this arterial supply. So this only applies for the first 10 intercostal spaces. Or first 9. And then you have, for posterior, again, you have the first 2 or 3 supplied by the subclavian and specifically the costocervical trunk. This is the superior intercostal supply. And then moving forward, we have the rest of them supplied by the descending thoracic aorta. And this is for the posterior supply. So again, generally, anteriorly is by the internal thoracic, posterior is by the thoracic aorta. Okay, and moving on, we have the nerves. So for the nerves, obviously you don't need to identify each of them on the cadaver, or I mean on the model, but just know that you have 12 intercostal nerves and they come from the ventral rami of the thoracic spinal nerves. So over here, it's coming off of the ventral rami, and also over here, I don't know if you can see it, but it's labeled. So it's coming off of the ventral rami, and then you have, as I said, you have 12 pairs. The typical ones, they only supply their intercostal space. So they are T1, T2, and then T7 to T11. They're called the typical intercostal nerves. The atypical ones, they're called atypical because they supply other things. They supply their intercostal space, and then they give branches to other places, and they work in other places, basically. So these are T3 to T6. And what they supply is cutaneous and cutaneous branches, anterior and lateral. So they supply parts of the skin. Collateral branches. So basically, whenever a vein goes through like a rib, or it goes across a rib, it gives collateral branches to the rib below it, and it's like above it. It goes above the rib, below it, to give a collateral branch. So it's supplying both. And these are like collateral branches here. You can see the rib, the same nerve itself is giving like a branch over here and a branch over here. So these are the collateral branches. So it's giving it to the rib below it on the superior surface. Okay, and then we have then you have also sensory branches from the pleural and peritoneum. So you can see that they're supplying stuff outside of the thoracic wall. And then you have the special nerves, the first and second intercostal nerves. They're called special nerves. Why? Because the first one, just know why they're called, why they're considered special. So the first one, it joins the brachial plexus, and it does not have an anterior branch. The second intercostal nerve, it joins the medial cutaneous nerve of the arm. So that's a special feature about it. And when you insert a needle, and whenever you're giving like anesthetics or anything, for any reason, if you're inserting a needle in the intercostal space, you need to be careful to do it on the upper border of the rib and not the lower, because that's where you have the neurovascular bundle. Okay, now for the lymphatic drainage, you have the lymphatic drainage of the chest wall. The anterior chest wall is by the anterior axillary nodes, and then posterior is by the posterior axillary nodes. For the intercostal space, again, anterior is the internal thoracic nodes, posterior is the periaortic nodes. So the lymphatic drainage of the intercostal spaces, they follow the arteries. So if you remember, the anterior arteries were the internal thoracic, were supplied by internal thoracic, and then the posterior was supplied by the aorta, the thoracic aorta, or sorry, the venous drainage. So yeah, we have okay, that's it for the lymphatic drainage. And now for the diaphragm. This part is very, very important for your OSPE. As I said, the other part might be more important for your MCQs, but this is very important for your OSPE. you need to know how to identify each part of the diaphragm and all of the openings. So you have 4 parts. The diaphragm attaches at 4 parts. First, you have the sternal attachment, where it attaches anteriorly, and then the vertebral attachment, or the lumbar part of the diaphragm. And then you have the costal attachment, where it attaches to the ribs on the sides, the costal part of the diaphragm. And then you have the central tendon. So the whole diaphragm over here is muscular. However, the inner portion is membranous. And in the membranous portion, you have the cable opening, which you have the inferior vena cava going through. And the reason why this needs to be in the membranous portion is because veins are low pressure. So if you put them inside a muscular portion that contracts, it can very easily get compressed. Whenever the diaphragm contracts, it will just compress the IVC if it was in the muscular portion. But in this case, it's in the central tendon to avoid it being compressed. So these are the 3 openings. So the first opening you have, as I said, is the IVC at T8. And then below that, you have the esophageal hiatus at T10 in the muscular portion. And then also in the muscular portion, you have the aortic hiatus, or not the muscular, more the lumbar part of the diaphragm. You have the aortic hiatus at T12. So remember, T8, T10, T12. Must know all of these, and you have to know how to identify it as well. So again, just to reiterate, in the central tendon, you have the cable opening. The cable opening takes 2 things in it, the IVC and the right phrenic nerve, which we said supplies the diaphragm, as Safia said. So you have the IVC and the right phrenic nerve. You have to know all the contents of the opening. Most important is IVC, but also know that right phrenic goes with it. Because they might ask you, okay, what structure goes here and what else accompanies it or something. And then you have the costal and lumbar parts, or the muscular parts. They have the esophageal hiatus. So the esophageal hiatus is at T10, and it carries 3 things. The esophagus, obviously, and then the vagus nerves. Vagus nerves supply the esophagus, so they go with it. And then you also have the left gastric, artery, and vein branches. So these are all part of the esophageal hiatus. And then you have the aortic hiatus, which is at T12. And the aortic hiatus is posterior to the diaphragm, as you can see here. And it's at T12. The things that go through the aortic hiatus is the aorta, thoracic duct, and the azygous vein. Again, I feel like we've repeated this concept so many times in different parts, so I feel like this should really emphasize to you how important this is. These are all posterior structures, the aorta, the thoracic duct, and the azygous vein. They're all posterior, and they all run together in the aortic hiatus. At which level? T12. Okay. Again, this is a model. So you can see the central tendon having the IVC opening, or the cable opening at T8. Below that, you have T10, the esophageal hiatus. And then below that, we have the aortic hiatus at T12. Okay. Now this is just a summary that you can go over. Now for the nerve supply, we have motor and sensory. The motor, as Safia mentioned, is the phrenic, C3, C4, C5, keeps the diaphragm alive. This is the motor supply. And then for the sensory supply, we have a different supply for the center of the diaphragm and the periphery. The center is supplied by the phrenic nerve, normally. But the periphery, however, is different because the intercostal nerves, basically, they go down at the same part that the diaphragm is like peripherally. So the diaphragm is dome from like throughout the whole, like from right to left, it goes. So the central part is by the phrenic nerve, but the outer parts, they're very easily supplied by the intercostal nerves because they're already supplying all the ribs that are surrounding it. So بالمرة, it also supplies the peripheral part of the diaphragm. Okay, so you have the lower intercostal nerves surrounding the periphery, and then the central part is by the phrenic nerve. Okay. Okay, so now let's get 2 questions. First, label structure X. So as you can see, it's here in the central tendon area. So what would it be? Okay. So this would be the IVC at level T8, and it's within the central tendon. And then 2 nerves supplying this structure. I mean, the whole diaphragm, by the way, not the IVC. Two nerves supplying it would be the phrenic nerve and the intercostal nerves, the inferior intercostal nerves. Okay, identify X and Y. Again, this whole thing is the central tendon. So X would be the IVC, and then the Y would be the esophagus or esophageal hiatus at T10. So T8, T10. Okay, now let's move on to the nasal cavity and larynx. Okay, so for the nasal cavity, first let's talk about the different regions of the nasal cavity. So you have three different regions. You have the vestibule, and then you have the respiratory region, and then you have the olfactory region. The vestibule is basically the opening of the nasal cavity, so it's the outermost part. And then you have the olfactory region is at the apex, so it's at the top over here. And the respiratory region is this part over here. And this is the part where you have pseudo-stratified epithelium ciliated with goblet cells, which we're going to see when we talk about the histology part of this. But yeah, these are just things to note, and make sure you know how to identify them. Now for nasal concha and meatuses. This is a very high yield concept. So concha are basically projections of bone that are in your nasal cavity. So you have a superior concha, a middle concha, and an inferior concha. And whenever you have a projection, it basically creates a space below it, which we call a meatus. So these spaces are just like places for air to pass, basically. So yeah, you have a superior meatus. Below it, you have a middle superior meatus. Then you have a middle concha. Below it, you have a medial meatus. Inferior concha, inferior meatus. So now let's move on to concept of paranasal sinuses. So paranasal sinuses, they are basically air-filled extensions within your nasal cavity, and they're all named according to the bone in which they're found. So you have the frontal sinus in the frontal bone. You have the ethmoid sinus in the ethmoid bone. You have the maxillary sinus, which is like here, your lower, like your upper cheek, in the maxillary bone. And then you have your sphenoid sinus over here. Now, the importance of these sinuses and why we're mentioning them is because these sinuses drain into the meatuses that we talked about here, these air-filled spaces. This is where the sinuses drain into. And different sinuses drain into different meatuses, and you need to be able to identify them. So this is the drainage of sinuses into meatuses, a very high yield. So first we have the sphenoid sinus. As we said, this was the sphenoid sinus over here and here. The sphenoid sinus drains into the sphenoethmoidal recess. So the sphenoethmoidal recess is this part over here. So it's between the sphenoid bone, and over here we have the ethmoid, or the superior concha is here, so it's like between them. So this is called the sphenoethmoidal recess, and it's where the sphenoid sinus drains into. The posterior ethmoidal, okay, so the ethmoidal sinuses, we have three. We have anterior, posterior, and middle. So the posterior one drains into the superior meatus. Again, here this is the superior meatus. This is where it drains into. And yeah. And then for the middle meatus, think of almost everything drains into the middle meatus. It's just certain exceptions that don't. So you have the frontal, you have the maxillary, the anterior, and middle ethmoidal all drain into the middle meatus. So these drain into here and over here. You have the middle meatus. Okay, and then the nasolacrimal duct drains into the inferior meatus. So it's this part over here, the inferior meatus. And this is why when you cry, you also sniff, or because they're connected, basically. And yeah, again, this is superior concha, middle concha, inferior concha. And then below it, you have superior meatus, middle meatus, inferior meatus. This is the eustachian tube, which is for equalizing pressure between the middle ear and outside. Yeah. Okay, so these are just more pictures. Again, just try to orient yourself with as many pictures as you can. This is the, here we have the frontal sinus, the sphenoid sinus, and then you have the concha and the meatuses between them, and the eustachian tube. And this is the sphenoethmoidal recess that we saw. Close. These are just the same stuff that we already mentioned. Okay, now let's move on to the larynx. So the larynx is basically just the voice box. So the larynx is, this whole yellow part here is the larynx, and it has different parts. So first you have the epiglottis. This is the most superior part, and the epiglottis is basically what closes when you're swallowing. to prevent food from going into the trachea. It wants it to go to the esophagus, so it will close so that food goes into the esophagus, not the trachea. And then parts of the larynx, we have the supraglottis, the glottis, and the subglottis. So starting with the glottis, because the rest are named according to it. The glottis is the middle part, the middlemost part, and it's where we have the vocal cords, which we're going to talk about. Above the glottis, you have the supraglottis, and then below it, you have the subglottis. So these are just the areas. And then for the vocal cords, we said that they're located in the glottis, and these are basically the vocal folds. They look like lips. So you have a upper and a lower. The upper one is called the false vocal cord. It's also known as the vestibular fold. And then below it, you have the true vocal cords. And between them is a place called a ventricle. And the vocal cord, it's attached anteriorly to the thyroid cartilage and posteriorly to the arytenoid cartilage. Okay, so now let's look at the laryngeal cartilages. We have two types. You have unpaired and paired. So the unpaired is only one, and then the paired comes as two on each side, like one on each side. So let's start with the unpaired. We have the epiglottis, which we already mentioned earlier. It's this thing over here. It's the uppermost. And yeah, that's the epiglottis. And then you have the thyroid cartilage. The thyroid cartilage is anterior. So this is the thyroid cartilage. And how do you know it's anterior? You have the cricoid cartilage also below it. So these are the rings, and you see these rings anteriorly. So whenever you see the cricoid cartilage, you know that you are anterior. And so above it, you have the thyroid cartilage. And then for the paired cartilages, we have the cuneiform, arytenoid, and corniculate. Cuneiform is, I don't think it's that important. And then you have the arytenoid. These two are the arytenoid, and they are above the cricoid cartilage on the back. So arytenoid is posterior, and so is corniculate. Corniculate is above the arytenoid. These two are the corniculate. And then this is the arytenoid, and this is the cricoid cartilage, as we said. Okay. Now, this is something that I told you guys earlier. Remember how I said the vocal cord is attached anteriorly to the thyroid cartilage and posteriorly to the arytenoid cartilage? This is what's happening here. Remember here, I said anteriorly to the thyroid, posteriorly to the arytenoid cartilage. So yeah, you can see that here. Now for the most important part of this is the laryngeal muscles. Laryngeal muscles now, they are basically, since the larynx is the organ of phonation or speaking, it's the voice box. So laryngeal muscles help you in different aspects of speech. Okay, so you have the posterior cricoarytenoid. Now, this muscle is found posteriorly, and it's attached to the cricoid cartilage and the arytenoid cartilage. So the name tells you everything that you need to know. The function of it is abduction of the vocal cords. So you can remember this as if you're abducting a child from their home, you're going to want to go through the back door instead of the front door, because the front door would be too obvious. So you're going to like abduct them and then go to the back door. So that's posterior for abduction. So obviously abduction means like you're pulling it away from each other. So if you're not able to do that, the vocal cords are just going to be closed like this. So imagine trying to speak when your vocal cords are like this, or it's very hard to abduct them. What's going to happen? You're going to have hoarseness in your voice. So your speech is not going to be that clear. People can't hear you that properly because your voice is very hoarse. And yeah, so you really need to know the damage of it, what happens if it gets damaged. And the nerve supply, all of the laryngeal muscles are supplied by the recurrent laryngeal, except for one exception, which we're going to talk about. So you have the, okay, someone is asking, can you show the abduction movement, please? Okay, so abduction is like away. Abduction, AB, means away, and then adduction is when you bring something together. So abduction is away. So that's the function of, that's how you abduct something. Sorry, abduction. Is that clear for the person who asked? Okay. So abduction is basically moving the vocal cords away from each other so that you can speak. Okay. And again, it's supplied by the recurrent laryngeal nerve, and damage to it would cause hoarseness in the voice. So where is the posterior cricoarytenoid? I told you guys it's posterior. So the first thing is, if you see these cricoid cartilages, you know you're anterior. So you're not going to find this muscle here. Do not look for it in this image. You're going to look for it whenever you don't see the cricoid cartilages. So here, the image is not complete, but there is no cricoid cartilages. So you know that you're posterior. So posteriorly, you'll have it attached to the cricoid cartilage, which is this, and the arytenoid, which is this. It's called the posterior cricoarytenoid. Clear? Very, very, very important to recognize this muscle. And then you have the cricothyroid muscle. This one is anterior, and as the name suggests, it attaches from the cricoid cartilage up until the thyroid cartilage. So you can see it here, cricoid up until the thyroid. And the function of this one is to tense the vocal cords. So you can picture this like a guitar, like the strings of a guitar, if any of you play guitar. So whenever you're trying to, whenever you like want to change the pitch of the strings, by the way, I don't play guitar, so I don't know how accurate this is. This is how I imagine it. So the strings of the guitar, basically when you change the pitch of it, when you like tighten it or loosen it, you're kind of changing the pitch of it. So you either have a high pitch or a low pitch, depending on how tense it is. So this cricothyroid muscle tenses the vocal cords. So it like pulls them to either tense them or relax them. So this movement is responsible for the pitch of your voice. So whether you have a high pitch or a low pitch, and you always have like the control to change the pitch of your voice if you want. Like I can make my voice lower, I can make it higher if I want. If you don't have this function, then you'll have a monotonous voice. So you'll be speaking like la 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 la. It's just like one tone. You won't have you can't increase your pitch or decrease your pitch. And the nerve supply of it is the superior laryngeal nerve. This is the one exception that I told you guys about. So remember, all muscles are supplied by the recurrent laryngeal nerve, except for the cricothyroid, it's supplied by the superior laryngeal nerve. Okay, and then damage to it, monotonous voice. These are some other muscles. They're not really as important and they're not really asked about, but I just put them for completion's sake, and even identifying them, they don't usually ask you to identify them, but you can, again, also just see it from the name of it. So this is the thyroepiglottic muscle, from the thyroid to the epiglottis, I guess. Thyroepiglottis, and then this is oblique arytenoid. This is transverse arytenoid, so it's going transversely between the arytenoid cartilages. So they're easy to like get the name of them based on their attachment. But again, focus on these two mostly. Okay, now for the questions. So first, identify the function of muscle X. And then which nerve supplies it? Does anyone know? Remember, first look if we are anterior or posterior. So can you see any cricoid cartilages visible?
The abduction of the vocal cords.
Yes, exactly. If you're going to abduct someone, you're going to take them through the back door. So posterior cricoarytenoid muscle, function of it, abduction, as you correctly said. And which nerve supplies it?
Recurrent laryngeal nerve.
Yes, perfect. And then the other muscle, cricothyroid, supplied by the superior laryngeal. Perfect. Okay. So what drains into X? Can anyone tell me?
The frontal.
Yeah.
The frontal maxillary.
Yes,
And
frontal maxillary.
And there's one more.
Yeah, there's anterior ethmoidal and there's middle ethmoidal.
Yep.
Yeah, so they all drain into the middle meatus. And then the superior meatus, you have the posterior ethmoidal. And yes, okay. Okay, now moving on to histology. Histology of the upper respiratory tract. So we're going to talk about the nasal region. So the nasal region has two portions. So I put this more as a question-based session because there's not much to explain. So if you know, can you tell me what this portion is? It's like the upper part of the nasal cavity. So what would it be? We talked about the regions earlier.
The olfactory?
Yes, exactly. The upper 1/3, this is the olfactory region. And, oh, sorry, I forgot to ask about the function. So the function of it would be to detect odor. So the olfactory region, upper 1/3, detects odor, and it's lined by olfactory mucosa. Next, we have this region. What is this region called?
The respiratory region?
Exactly. And function of it, do you know?
To humidify the air and to trap the bacteria.
Exactly. So it warms, moistens, filters the air, and also has a function in the local immune response. So the lower 2/3 is the respiratory region, and it's lined by respiratory mucosa. So now we're going to look at each of them more up close. So can anyone tell me what type of epithelium we can find here? So you already know it's respiratory mucosa based on the picture, but what type of epithelium is it?
Respiratory epithelium?
Yeah, what is it specifically?
Pseudo-stratified columnar ciliated epithelium.
Yes, with
Cilia?
what? Cilia and?
Goblet cells?
Yes, with goblet cells. Perfect. You really need to actually like say the whole name in the exam. You might get some marks for saying the rest. You will, and obviously, but try to say the whole thing. Ciliated with goblet cells and pseudostratified columnar. Okay, so this is respiratory epithelium and it has goblet cells. So this whole thing is the respiratory mucosa. You have the lamina propria more on the outside, and then the respiratory epithelium towards the lumen. So the respiratory epithelium, as you correctly said, is the pseudostratified columnar with goblet cells, ciliated. The lamina propria, it includes loose connective tissue, and it has blood vessels, which are for warming the area. And it also has seromucinous acini. So it secretes serous and mucus, which supplements the secretions of goblet cells. So we know goblet cells are the main cells that secrete mucus, but these acini over here, they look like acini, they secrete, they're seromucinous. Just a second. Okay, so now basically zooming into this even further, or talking about them more in detail. So in the lamina propria, so we have, first of all, we have these basal cells. So they're at the base. They don't go up until the epithelium. They sit here, which is like between the lamina propria and the epithelium. So you have these basal cells, and their function is basically to give rise to other epithelial cells. So they're like stem cells. And then you have ciliated cells, which are here. So they have, they contain, they're the most abundant, and they are tall columnar cells with motile cilia. Very important that it's motile because we're going to compare it to the other epithelium, which is not motile. But yeah, it has motile cilia, and the function of it is for the mucociliary escalator. So basically, whenever you have foreign particles that come in to your nasal region, the cilia is going to like sweep them away into either your throat, like your throat, so that you can either swallow them or like cough them out. So yeah, this function is very important. And you have over here, you have the cilia itself, and here are the ciliated cells, which are columnar cells, pseudostratified columnar. And then, so yeah, this part is the respiratory epithelium. And then we have the goblet cells, which secrete mucus. And then you have these vessels over here in the lamina propria that we said they are for warming and humidifying the air. And these are the seromucinous acini again that I mentioned. Next, we're going to look at this epithelium. So which type of epithelium can be found here? So this is olfactory mucosa, as you can see. Does anyone know? Very similar to the one earlier. There's just one small difference. Anyone know? Okay, it's fine. So it's pseudostratified, columnar, ciliated with no goblet cells. So everything is the same except it does not have goblet cells. Because when you think of it, the function of this, as we said earlier, is for odor detection. It doesn't really have to like fight off infections or trap any foreign objects or anything. It's just for odor detection. So it doesn't need goblet cells. So we have, so yeah, this is the whole mucosa. And in the inner portion, closer to the lumen, you have the epithelium. And then here you have the lamina propria. The lamina propria includes, again, blood vessels, and it has olfactory glands called Bowman's glands. And these secrete serous watery fluid. So compare these to the respiratory region. It had seromucinous. This one is only serous watery fluid for dissolving odorous substances, which is detected by cilia. So the function of cilia here is just for detection. It's not for sweeping or anything. So keep that in mind when I explain it. So we have basal cells. Again, same thing. Basal cells, we have them at the base between the lamina propria and the epithelium. And their function is to give rise to other olfactory receptor cells and supporting cells, which are found in the epithelium. So that brings us to the supporting cells. These are the supporting cells, and their function is to provide support, both mechanical and metabolic, for the olfactory receptor cells. Okay, now the olfactory receptor cells, they are bipolar olfactory neurons, and they have immotile cilia. Because as we said, the cilia here, the function of it is not to sweep something away or to move anything. It's just for detecting odor, so it doesn't need to move. So this is immotile cilia. And then again, we have Bowman's glands in the lamina propria. This just looks like a gland. These are how glands look. So yeah, we have lamina propria and the epithelium. Next, we're done with it. So I just put this summary slide so we can compare them. So respiratory, does it have gallbladder cells or no?
Yes, it does.
Yes, present. Olfactory?
No.
No. What about the cilia in respiratory? What's the difference between them?
For the respiratory, it's for the movement of the particles, whereas in olfactory, it's for the detection of the odor.
Yeah, so this is mobile and this is immobile. Correct. And seromucinous acini, do we have it in respiratory or no?
Yes.
Yes. And in olfactory?
No.
No, we just have serous. And then it's thinner and shorter and thicker and longer in olfactory. Function of respiratory?
To humidify the air.
Yeah, conditioning, which is basically humidifying and everything. Function of olfactory?
To detect the odor.
Perfect. Okay, now you guys are pros. So which slide is B and name its function? So B, what is this? Okay, so B is the olfactory epithelium, and the function of it is detecting odor. A would be the respiratory epithelium. Okay.
Okay, so now we're going to move on to the lower respiratory tract, as well as the lungs and the pleura. So let's start with the trachea. So the trachea, it arises at the lower border of the cricoid cartilage. So you can think of it as an extension of the larynx at C6, and then it goes all the way down to the level of T4, T5, and this is where it bifurcates into the right main bronchus and the left main bronchus. So there's something very important that you have to know about this bifurcation. First of all, the level, T4, T5, is very important to know because this question, it can come in your OSPE, and you can also use it to identify the location of where you're at when you're looking at the anatomy slides, as well as the CT scans. And you also have to know about carina. So carina, that is the name of the cartilage at the level of T4, T5, and it's very, very important as a landmark for bronchoscopy. So when they're visualizing inside the trachea, they know that they're at the bifurcation because of carina. So the trachea, it travels inferiorly from the superior mediastinum, and it bifurcates at T4, T5, which is also the level of the sternal angle, and it's located anteriorly to the esophagus, and it inclines slightly to the right. Okay, so the trachea has these very distinctive C-shaped cartilage rings. However, it's not a full ring. It's a C-shaped cartilage ring, and then the last part is muscle. It's a trachealis muscle. So does anybody know why it's not a complete ring of cartilage?
So that the esophagus behind does not get collapsed.
Yes, exactly. So the esophagus is located directly behind the trachea. If the trachea had complete rings of cartilage, then that would compress the esophagus and food would not be able to travel into your stomach. So it's lined with the mucociliary escalator. So that's something that we're going to discuss a little bit more when we talk about the histology of the trachea. But for now, just to give you guys an idea, the function of the mucociliary escalator is basically to trap pathogens and dirt and debris and move it out of the way to prevent any infections. So the sensory innervation by the trachea is done by the recurrent laryngeal nerve. The arterial supply is by the tracheal branches of the inferior thyroid artery, and the venous drainage is through the brachiocephalic and the azygous and accessory hemiazygous veins. Okay, so this is just a model of the trachea, just to show you guys that it starts below the cricoid and it goes all the way down. And here is a photo that shows you guys the relationship between the trachealis muscle and the esophagus. So notice how the muscle, which is one wall of the trachea, it's directly in front of the esophagus, and this prevents the compression of the esophagus by the trachea. All right, now let's talk about the lungs. So each lung has an apex, which is the top here, and this top is located above the clavicle. It has a base, which rests on top of the diaphragm, and it has lobes. So the lobes are divided by these fissures, and you have two fissures. You have a horizontal fissure, which runs from the inferior border of the lung until it meets the posterior lung border. And you have that's the oblique fissure. It runs from the inferior border of the lung until it meets the posterior lung border. And then you have the horizontal fissure, which runs from the sternum all the way from the level of the fourth rib to meet the oblique fissure. So in the left lung, it's going to divide it into two lobes, the superior lobe and an inferior lobe. While in the right lung, you're going to have a superior lobe, an inferior lobe, and a middle lobe. So the lungs have three surfaces. There is a mediastinal surface. So from the name, you can tell that it faces the mediastinum, and this is where the heart would be. And this faces the lateral aspect of the mediastinum. So it would be the medial surface of the lung, but it would face the lateral aspect of the middle mediastinum. The base of the lung is formed by the diaphragmatic surface, and it's called that because it rests on top of the diaphragm, and it has a concave shape to make room for the diaphragm. And then you have a costal surface. So the costal surface is very smooth, and this is the outside surface, and it's called costal because it faces the ribs and the costal cartilages. And it is related to the costal pleura. So remember the pleura that we talked about earlier, and we're also going to discuss in a little bit more detail. Okay, so the lung has three borders, and these borders are very, very important because they can help you in differentiating between the right lung and the left lung. So you have an anterior border, which is this right here or here, and this is formed by the convergence of the mediastinal, so the surface that's on the inside, and the costal surface, so the surface that's on the outside. And one thing to know about the anterior border is that it tends to be very sharp. So an easy way to remember this is that the letter A is sharp, and so is the anterior border of the lung. And then you have an inferior border. So the inferior border, it's going to separate the base of the lung, so here, from the costal and the mediastinal surfaces. And then you have a posterior border. So this posterior border, compared to the anterior one, it's smooth. So an easy way to remember this is the letter P is rounded, just like the posterior border of the lung. And it's formed by the costal and the mediastinal surfaces meeting posteriorly. So each lung has a root. A root is the collection of arteries and veins and bronchial vessels and pulmonary plexuses that are actually entering the lung and leaving the lung. Now, the reason why I say entering and leaving is because you have the pulmonary arteries, for example, they would be entering the lung carrying deoxygenated blood, and you have the pulmonary veins, which are leaving the lung carrying oxygenated blood. And all of these structures, they enter or leave the lung via a structure called the hilum, which is a wedge-shaped area on the mediastinal surface. So here. Okay, this is a very, very, very important question, and it comes in almost all the OSPEs, which is to differentiate between the right and the left lung. So does anybody know how to do that? Okay, so I'll tell you that, first of all, the left lung, it has two additional structures that you don't see in the right lung, which is here the cardiac notch and the lingula. So the lingula is just an extension of the superior lobe, and the cardiac notch, it's this little, I would say, So the lung in the right lung, it's like continued, but the cardiac notch, it's almost as if a section of it is missing. And this is just to make space for the heart. That's one way to tell the difference. But the easiest way, at least for me when I was in first year, is to determine which one is the anterior border and which one is the posterior border, and then imagine the lungs in yourself. So for example, A, the anterior border is sharp, so this would be the anterior border, and P, the posterior border, is rounded, so this is the posterior border, meaning that the orientation of this lung has to be this way, meaning that it's the left lung, and then it's the same for the right lung. Another thing that's extremely important is you have to know the impressions of the vessels and the heart on the lungs. So let's start with this lung. This is the right lung. And you can see the impression of the esophagus, the trachea, the brachiocephalic vein, and the superior vena cava. So the superior vena cava is always a structure that's located on the right, so you would see its impression on the right lung. This is in contrast to the left lung. So the left lung would have an impression of the aorta. This is the most important because the aorta tends to be a structure that's more on the left side. And you would also see the brachiocephalic vein, subclavian artery, and you could also visualize the trachea and the esophagus here. All right, so let's talk about the blood supply of the lungs. So deoxygenated blood, that's by the pulmonary arteries, and oxygenated blood is going to leave the lungs via the pulmonary veins and go to the heart. Now for the bronchi and the supporting tissue, they receive their nutritive supply from the bronchial arteries, and their venous drainage is through the right bronchial vein into the azygos. And then the azygos vein and the left bronchial vein drains into the accessory hemiazygos vein. And each of the alveoli, so when you go deeper and deeper into the lungs, you'll see the alveoli, each one of them has its own capillary network. As for the lungs' nerve supply, you have pulmonary plexuses, so you have 3 of them. First one is parasympathetic. So the function of the parasympathetic nervous system in the lungs is to stimulate bronchial gland secretion and bronchial smooth muscle contraction, and it causes pulmonary vasodilation. So remember that it causes the opposite thing in the blood vessels versus the bronchi. So if it dilates the blood vessels, it's going to constrict the bronchi and vice versa. So parasympathetic, it contracts the bronchioles, and it vasodilates the arteries. Sympathetic is going to do the opposite. So the function of the sympathetic nervous system in the lungs is to relax the bronchioles, so there would be bronchial dilation, and there would be pulmonary vasoconstriction. And then the last plexus is the visceral afferent, so this is just to conduct pain impulses. For the lymphatic drainage, you have 2 lymphatic plexuses, and both of these are going to drain here in the inferior tracheobronchial nodes. These are very, very important to know, and the inferior tracheobronchial nodes, an important anatomical landmark for them is carina. So they're located near carina. All right, so let's move on to the pleura. So the pleura are these coverings that are located around the lungs. They're serous membranes, and you have one for each layer. So you have a parietal one and you have a visceral one. So earlier, when we were talking about the pericardium, we mentioned that the word viscera refers to organs. So if we're talking about a covering that's called visceral, that means it's going to be adherent to the organ. So between the parietal pleura and the visceral pleura, you're going to have a gap. And the pleura itself can further be subdivided according to the location. So we have four divisions of the pleura. We have the mediastinal pleura, so from the name, it's going to face the mediastinum. We have the costal pleura, so from the name, this is going to face the costal ribs and the cartilages. And we have the diaphragmatic pleura, which you can't visualize here because it's located below, and the cervical pleura, which you can't visualize here because it's located above. So between them is the pleural cavity, and in the pleural cavity, you're going to have pleural fluid. And pleural fluid has 2 main functions. The first one is to reduce friction between the layers of the pleura, and the second one is to maintain surface tension. So what do we mean when we say maintain surface tension? So you know that when you breathe in your thoracic cavity or your thoracic cage, it's going to expand. So the surface tension here, it's going to help pull on the lungs, and that's going to help the lungs expand to allow air to come in. Okay, so the pleural cavity, it's not completely filled by the lungs. You actually have 2 recesses. So you have the costodiaphragmatic recess, which is located right here, and the costomediastinal, which is located behind the sternum. And these have very, very important clinical functions. So the costodiaphragmatic recess, it forms this angle right here. And if you have fluid buildup in the lungs, or in the cavity for any reason at all, you would be able to visualize it here. So you would see it on X-ray, and that would indicate that you have a condition like pleural effusion or some other fluid. It could be blood, it could be anything. So the parietal pleura is sensitive to pressure, pain, and temperature, and it's innervated by the phrenic and the intercostal nerves, so this produces a very localized pain. Compared to the visceral pleura, which are not sensitive to pain or temperature or touch, they are only sensitive to stretch, and they receive autonomic innervation from the pulmonary plexus. The arterial supply of the visceral pleura is the bronchial arteries, while for the parietal pleura, it's the intercostal arteries. So the intercostal arteries would be located here, and that is right next to where the parietal pleura is. Okay, so for the bronchopulmonary segments, I don't think you have to know all of them in details, but what you should know is that within each lobe you have different segments, and each bronchopulmonary segment has its own bronchus and its own blood supply. Therefore, if you resect one, the others would still be able to function and you could survive without the complete lung. All right, so now talking about pulmonary embolism. So what is pulmonary embolism? It's when you have the formation of a blood clot and that gets trapped here in the lungs. So when it gets trapped here in the lungs, it blocks blood flow, and that is going to cause a reduction in lung perfusion. So the patient is going to come to you and they're going to present with dyspnea, which is difficulty breathing or pain breathing. They're going to have chest pain, they're going to have cough, they might be coughing up blood, and they would be breathing very fast, which is tachypnea. So the way that this is treated is with anticoagulation. So anticoagulant drugs, they basically stop the formation of blood clots, and thrombolytic therapy, which works to dissolve the blood clot that has already formed. All right, so please identify if this is a left lung or a right lung. Okay, so this would be a left lung. First of all, you have the presence of the lingula, which seems like this extra or this extension of the superior lobe, and you have the cardiac notch. And another way to tell is that this is the anterior surface because it's a little sharper. This is the posterior surface, so just imagine it like this, and it would be the left lung. All right, identify the structure and the level at which it bifurcates. Okay, so this is the trachea, and it bifurcates at the level of T4. All right, and identify the different parts of the pleura. So this would be the costal pleura, this would be the diaphragmatic pleura, this would be the mediastinal pleura, and up here would be the cervical. And if you have fluid buildup for any reason, you would see that the angle of the costodiaphragmatic recess is reduced. All right, now let's talk about the histology of the lower respiratory tract, starting off with the trachea. So the trachea has 4 layers. It has a mucosa, a submucosa, a cartilaginous layer, and an adventitia. So let's start off with the mucosa. It is made up of respiratory epithelium. So respiratory epithelium is the pseudostratified ciliated columnar epithelium with goblet cells. So as Shahad was mentioning earlier, it's very, very important to know the full name of the respiratory epithelium. Directly underneath the respiratory epithelium, you have the lamina propria, which is just a layer of connective tissue. Underneath the lamina propria, you have the submucosa, which again is connective tissue, but it's a little bit looser. And here you would see blood, lymphatic vessels, and serum mucinous acini. And then you have the cartilaginous layer, which is made up of hyaline cartilage. So hyaline cartilage has a very, very unique appearance. There's nothing else in the human body that looks like this, and it's the only, well, it has a very distinctive appearance, and it takes up the stain so intensely. So if you look at the rest of these cells, they're pink, but the cartilaginous layer is purple. And then lastly, you have the adventitia, which is again another connective tissue layer, and this helps bind the trachea to adjacent structures. So let's take a closer look at the trachea. This is a transverse section. So here we can see the respiratory epithelium, which is ciliated pseudostratified columnar epithelium with goblet cells and basal cells. So the full name of this is very, very important. And then you have a basement membrane, which is made up of densely packed collagen fibers, and it's located directly underneath. And then you have the lamina propria, which is the cellular loose connective tissue. And it's very, very rich in elastic and collagen fibers. And here you would still be able to see some serous and some seromucinous acini in the submucosal layer. So this is a longitudinal section of a trachea. And here you can appreciate the adventitia. So this would be the outermost layer that connects the trachea to adjacent structures. You can see the hyaline cartilage, the lamina propria, which is the connective tissue layer that's directly underneath the respiratory mucosa, which is here. All right, so now let's go a little bit deeper. After the trachea, we are going to see the bronchus. So when the trachea divides, it forms these bronchi. And the main differences between the bronchi and the trachea when it comes to histology is that instead of having a cartilage ring, you're going to start to see these plates, these cartilage plates. So it's not going to be a regular smooth layer, it would just be in plates. And then you would also have the addition of smooth muscle to form a complete circumferential layer. So earlier in the trachea, we talked about how the trachea has only one section of smooth muscle, which is the trachealis. But here in the old intrapulmonary bronchus, the whole thing would be surrounded by smooth muscle. And again, we would have a mucosa layer, which contains the epithelium. It would contain the lamina propria, which is the connective tissue, the muscularis layer, the submucosa, the cartilage layer, which are these plates instead of the ring that we saw in the trachea, and also the adventitia. Okay, so once you go a little bit deeper into the tracheobronchial tree, after the bronchus, you would see the bronchiole. So as for the epithelium of the bronchiole, this really depends on whether it's a large bronchiole or a smaller bronchiole. So larger bronchioles, their epithelium would tend to resemble that of a trachea a little bit more, and that of a bronchus a little bit more, where you would see ciliated pseudostratified columnar epithelium with goblet cells, but smaller ones would only have simple ciliated columnar or cuboidal epithelium, and they would have less goblet cells. Then you would also have the lamina propria, which is this connective tissue layer, the muscularis, which is going to be that layer of smooth muscle, and then the adventitia, which is the connective tissue, and it's going to connect it to the surrounding alveoli. Okay, so let's just take a quick moment to differentiate between a bronchus and a bronchiole. This is also a very important concept, and right away, the most important difference that you can see is the presence of these cartilage plates. So these cartilage plates would be found in the bronchus, but they would not be visible here in the bronchiole. Okay, the next bronchiole, or as we go a little bit deeper, would be the respiratory bronchiole. So the respiratory bronchiole is made up of simple cuboidal epithelium, ciliated cells, and club cells, and you would also see smooth muscle fibers and elastic fibers. But here at this point, you do not have that adventitia outer connective tissue layer, and you do not have the cartilage anymore. So this is just another section of respiratory bronchiole. So you can see how it is surrounded by alveoli and it has smooth muscle. And then we're going to move on to the alveolar ducts. So the alveolar ducts are elongated airways basically, and they don't have any walls. Instead, they're surrounded by alveolar sacs. They have smooth muscle rings that are located between the septa. And then at the end here, you have the alveolar sacs, which are spaces that are surrounded by the alveoli. And then they typically happen at the end of an alveolar duct. So it would be the duct and then the sac at the end, but it could actually happen anywhere. Typically, it can occur anywhere. Okay, so this is just a closer look at the alveoli. So there are three main types of cells that you have to know for the alveoli. The first one is type 1 pneumocytes, the second one is type 2 pneumocytes, and the third one is alveolar macrophages. So type 1 pneumocytes, their function is just gas exchange. They're extremely, extremely thin squamous cells, which helps with their function because you do want very thin cells to help with gas exchange. And this is what they look like. You can see that they have a very, very flat nucleus, and they appear very, very thin. The second type of cell is the type 2 alveolar cells. So these are a little bit thicker because they're cuboidal cells, and their function is that they're progenitor cells for type 1 and type 2. So they divide to form those type 1 pneumocytes as well as type 2 cells, and they secrete surfactant, which is the fluid. And then the last type of cell is the alveolar macrophage, which I don't think you can appreciate here, but just from the name, it's a macrophage, so it is an immune cell. It removes inhaled particle matter and red blood cells that could enter this area, because if red blood cells enter here, it could cause or they would enter here in the cases of heart failure, so it would be the macrophages that would remove them. All right, now let's talk about the visceral pleura. So the visceral pleura is made up of simple squamous mesothelial cells. This kind of resembles the visceral pericardium cells that we were talking about earlier, where it's a very thin, one-cell thick layer with a very flat nucleus. So this produces the serous fluid that acts as a lubricant that we were talking about earlier. So it works to lubricate and reduce friction, as well as help with surface tension, increase the surface tension to help pull those lungs and open them up when you're breathing in. And you also have a thin connective tissue layer, which helps with flexibility. And it's made up of collagen and elastic fibers. Okay, so can you identify what this is and just one type of cell here? So this is the alveoli, and here you would be able to see type 1 pneumocytes, whose function is gas exchange, type 2 pneumocytes, whose function is to make more type 1 and type 2 pneumocytes and also secrete surfactants, and alveolar macrophages. All right. So this is a bronchus, and you can tell that it's a bronchus because it has these cartilage plates. So it doesn't have a full cartilage layer or a cartilage ring like the trachea does, but it also does have cartilage as opposed to the bronchiole, which doesn't have. And this is the trachea. All right, so now we're just going to go over a few radiology images. So the first thing that we have to know is that when we're doing radiology images, they're typically done in a posterior-anterior view. So that means that the machine would be giving these rays or distributing these rays, and they would go through the patient's back and into the receiver part, which would be through the patient's front. So the picture is basically taken from the back, and this is just to give us a better view of the mediastinum in the heart and the structures inside. So this is a heart, as you can tell by the shadow. First thing that we have to talk about is the fact that air in these x-rays appears black. So all of this is air, and these organs would appear white, or they would have a more intense color. So again, this would be the patient's right, so it's opposite of your right, and this would be the patient's left, so it's opposite of your left. So on the patient's left here, you can identify this is the apex of the heart, this is the left ventricle, and this is the left atrial appendage. So the left atria would be here. And here is the pulmonary artery, which drains into the left atrium. And here is the aortic knuckle. So because the aorta kind of bulges out due to the arch, it has this distinctive shape called the aortic knuckle. Here you would see the superior vena cava, which is going to drain into the right atrium. And here is the inferior vena cava, which also drains into the right atrium. Here you can see the trachea, and the trachea bifurcates here. So this is the level of about T4, where you would see the carina. And here you have the costodiaphragmatic recess, which we were talking about earlier. So this has an important clinical significance. If you have any fluid buildup here for whatever reason, this angle would disappear. And let's take a lateral view of it. So over here is the heart, and you have the hilar region, which is over here. You can kind of tell that it is the hilar region because you have these little white dashes which show you where the blood vessels are leaving from. And then you also have the thoracic spine, which is made up of these vertebrae. You have the diaphragm, and here is the costophrenic recess. So this is an aortography. It is basically a technique to help you visualize the aorta and all of its vessels. So if there's any blockage somewhere, you should be able to see it through here. So let's just start here from the ascending aorta. So this is the part of the aorta that comes directly out of the left ventricle. And this is the arch of the aorta, and it's going to go and form the descending aorta, and then finally the thoracic aorta. And from the thoracic aorta, it's going to continue down and become the abdominal aorta. So the main branches that the arch of aorta gives off is the brachiocephalic trunk, and the brachiocephalic trunk is going to further divide to give you the right subclavian and the right common carotid artery. As for the left common carotid artery, it comes directly out of the arch of the aorta, and the left subclavian artery also comes directly out of the arch of the aorta. This artery right here, the axillary artery, is basically the continuation of the subclavian artery. And these other arteries, first of all, these ones are intercostal arteries. So these are going to go to supply the ribs and the intercostal spaces. And I think those are the most important ones, but if you'd like to go through the rest, you can go through them here. And this is a bronchiogram. So the bronchiogram is to help you visualize the trachea, the tracheobronchial tree. So you can see the trachea, you can see how it divides into the bronchuses or the bronchi, and how the bronchi divide into bronchioles. And one thing to note is that the shape of the right bronchus is different from the left one. So the right bronchus tends to be shorter, it tends to be wider, and therefore it is more prone to obstruction, especially in kids. So if you have a kid who swallowed something he wasn't supposed to swallow and he choked on it, or it entered his airway, it would more likely be found in the right bronchus as compared to the left one. All right, so identify the structure. So this is the aortic knob, and it signifies where the arch of the aorta is. Identify the structure. So this is the costophrenic recess, and the significance of it is that if there's any fluid buildup, this angle would disappear and you would be able to see it.
I'm sorry, just give me a second. Okay, so now we're going to talk about the anatomy. So basically, this part, a lot of it is going to be very familiar to you guys because you discussed it in the mediastinum part. We're going to go over like each level, or not each level, most of them. So before we start, I just want to recap everything that we already know. So first, we're going to look at the arch of the aorta, or the aorta itself. So the aorta, as we know, it has an ascending that starts anteriorly and then it goes posteriorly to descend. And as it goes, it gives off, you have an ascending aorta, and then it arches, and then you get the descending aorta. The arch of the aorta has branches. Again, we talked about this a lot, so I don't want to spend too much time on it. But these are the branches of it. So at T3, the first part where you cut the aorta, first you're going, or like you get a cross-section of the body. The first thing that you're going to see are these vessels right here, which is the left subclavian, left common carotid, and the brachiocephalic. And you're going to see them in that order, and from anteriorly to posteriorly. So first you're going to see the brachiocephalic, and then the left common carotid, and then the left subclavian, if you cut at the level of T3. At T4, you're going to start seeing the arch, and then you go more below, and you're going to see the ascending and descending aorta, and you're going to see them even at like T5 again. But then when you reach up until after that, like T7, you're only going to see the descending aorta. Okay. Now for the SVC, again, we know that it has two tributaries, the right and left brachiocephalic vein, which join together to form the SVC. So these are them coming here, the right brachiocephalic and the left brachiocephalic. So if we take a cross section at T3, or like above the part where the SVC forms, we're going to see these two veins, and we're not going to see the SVC yet because they still didn't join to form it. So you're going to see them as individual structures, and you're going to see the left brachiocephalic as a horizontal structure, because as you can see, it starts from the left side because it's the left brachiocephalic, but it has to drain into the SVC, which is on the right side. So it's going to cross over and drain into the SVC. So this is why you see the left brachiocephalic as horizontal, and this is very important. And yeah, and you're going to see them next to each other, so you're going to know it right away. And then further down, you're going to see the SVC. And then further down, you're going to start seeing the azygos, which drains into the SVC. And then you're also going to be seeing the SVC with it, because, you know, it's still there, it still exists. Now for the pulmonary trunk, again, you know that you have the pulmonary trunk. From the pulmonary trunk, we have the right and left pulmonary arteries. So first, you're going to see the pulmonary trunk alone, And then the next level, you're going to see them branching. It branches really quickly. So at T4, T5, you'll see the trunk, and then T5 plus you'll see the arteries. And then you have the trachea. Again, we already discussed this, but it begins at C6 and then it goes all the way down until T4, T5, where it bifurcates and you see the right and left main bronchi. So at this point, below that, you're not going to see the trachea. You're going to see the bifurcation. Okay, so let's start with T3. Let's think about it the way that we just learned it. Okay, so T3, let's think of it from the aorta perspective. What are we going to see in the aorta? We didn't reach the arch of the aorta. We just have all the branches. So we're going to see all the branches that we talked about. And I told you guys, by the way, this is anterior and this is posterior. So the most anterior structure is going to be the brachiocephalic artery. That was the branch that we got from the aorta. Next to it, we have the common carotid, left common carotid, and then the left subclavian. So okay, we know 21, 22, 23. Let's just look at it. Okay, so 21, 22, 23, we have the right brachiocephalic artery, the left common carotid artery, and then the left subclavian. Okay, done with the aorta. Now let's look at the superior vena cava. What did we say about it at T3? It's still, the veins did not join together to form the SVC yet. So we only see the tributaries, which as we said, is the left brachiocephalic and the right brachiocephalic. And what did we say was very identifying feature of the left brachiocephalic is that it's horizontal. So the number 20 here, we can see that it's horizontal and it's going like towards the right side. And 19 again is another vein. Usually if you see stuff on the right side, they're the veins. So this is the right brachiocephalic vein and this is the left brachiocephalic vein. Okay. Literally just by knowing this, we've covered almost everything in here. Next, easy, we have the esophagus. Esophagus is the most posterior. And then in front of it is the trachea. So okay, you know, esophagus and trachea. Close, you got that. The rest, the right and left lung, very obvious. Right lung, left lung. And then these that I highlighted in a very light color, they're just really not important, but I just put them for completion's sake. So here we have the vertebrae, and then here you have the sternum. So this is anterior and posterior. Okay, that's it for T3. Now let's look at T4. So let's first think of the aorta again. So we finished from the branches of the aorta. Now what are we going to see? We're going to see the arch of the aorta. So this big thing here, it just looks like really funky and it's the arch of the aorta. Okay, so it's going from anteriorly and it's going down posteriorly. So that's how it arches. So we have the arch of the aorta. That's it. And then what about for the SVC? At this point, they join together, the right and left, and they form the SVC. So you're no longer going to see two separate veins. You're just going to see the SVC, which is at 18. Okay, and then what do we have left? The esophagus, as we said, is the most posterior, so it's 5. And then number 6, the trachea, it's anterior to the esophagus. Okay, and then you have the right and left lung, you have the sternum and the vertebrae. Done. We just finished that part. Now we have, by the way, if I'm going too fast and you have a question, please unmute and ask. I just don't want this recording to be even longer than it is. So for T4, T5, okay, now let's look at the aorta again. We finished from the arch of the aorta, so now we're going even further down. So now we're going to be seeing what? The ascending and descending aorta. And as we said, the arch of the aorta starts anteriorly and then it goes posteriorly. So most anterior is going to be the ascending aorta, and then picture it going down and descending into the descending aorta. So you see the ascending and descending aorta. Perfect. Now what about for the SVC? Again, we still have the SVC, but what else do we have now? We have something draining into the SVC. So this is the SVC, this is something draining into it. So what could this be? The azygos. So 25 is the azygos, and then 18 is the SVC. And then we said the ascending and descending aorta. Again, here, 5 is the most posterior, so it's the esophagus. What did we say is in front of the esophagus? The trachea. But here, we are already past T4. So the trachea has already started bifurcating. So you can see the right main bronchus and the left main bronchus. It's no longer the trachea, it's bifurcated. So again, it's still in front of the esophagus, so you can still picture it and make it make sense. And then you have, again, the right and left lung, manubrium, and the vertebrae. We covered everything. Now for T5. Now T5, for the aorta, we still only see the ascending and descending. So we have the 7A and 7C. These are still the ascending and descending aorta. by the way, here before that, we haven't been seeing the, sorry, I forgot to mention the pulmonary trunk. So the pulmonary trunk is right next to the aorta, and we started seeing it at this level. Here, we weren't really seeing it. Here, we started seeing it. So next to the aorta, you have the pulmonary trunk. So this is the pulmonary trunk. It hasn't yet divided into the right and left pulmonary arteries. However, the next slide, you'll see that it is dividing actually, and you can even see it going towards the lung. So right away that you know that this is the main pulmonary trunk, and then this is the left pulmonary artery going towards the left lung, and this is the right pulmonary artery going towards the right lung. And then you have, as I said, the ascending and descending aorta. You have the esophagus at 5 still, and you still have the bronchi, the left main bronchus and the right main bronchus. This is still the SVC, and we said you can still see the azygos here. So 25 is the azygos. I know it's not directly like draining into, you can't see it directly draining into the SVC because at this point it's still ascending upwards to go to the SVC. But still, this is the azygos. So yeah, we covered this, we covered that, we covered everything. Okay. And then you have the sternum and the vertebrae. Now we have the last level for this section. We have T7. So T7 is when you're actually going to start seeing the heart. So the most anterior structure. So let's look at this. So the heart, we have the most anterior structure. Here is the, wait, where are we? Okay. The most anterior structure here, this is the right ventricle. And then we have, next to it, obviously, is the right atrium. And then posteriorly, we have the left atrium. Left atrium is the most posterior, so you can see it closest to the vertebral column here. Most posterior is the left atrium. Most anterior is the right ventricle. And then next to it, you have the right atrium and the left ventricle. The left ventricle, you can also identify it because it has a very thick wall. So this is the left ventricle. And then you also have this thing coming out of the left ventricle, which is the papillary muscle. So this from here, this number 10 is the papillary muscle. Okay. And then what else do we have? So we have the moderator band here, because we know that this is the right ventricle. So what are we going to find in the right ventricle? As we said, the moderator band. Left ventricle, we have the papillary muscle. And then, yeah. Okay, number 32, what could this be? So it's between the two atria, between the two atria. So it's the interatrial septum. These are the ventricles, these are the atria. So this is the interatrial septum between the two atria. And then number 9, we have the fossa ovalis. Again, fossa ovalis is between the atria. So you would find it here, and you would also find the interatrial septum. So these two things between the atria. Yeah, that's mainly it. They probably won't ask you like that many details about the structures within it, but yeah, they're easy to guess, sort of, or just logically guess. And then again, we still have 5 as the esophagus. We still have the azygos vein at 25. And then this is the descending aorta. As I told you guys, the descending aorta is going to continue all the way down. So you can still see the descending aorta here. And then you have the right and left lung. And I think I covered everything. Okay, so that was for these sections. Next, we have a coronal view. So coronal view, you're basically just looking at the heart, like it's like you're looking at the person from the front. So it's very easy to identify everything if you know the anatomy of it. So we have 19 and 20. They are the brachiocephalic veins. They're joining to form the SVC. And then next to it, we said we have the aorta. So now we have the aorta here. And then next to the aorta, we have the pulmonary trunk. So we have SVC, aorta, pulmonary trunk. And then over here, of course, you have the heart. So this structure here with the very thick wall is the left ventricle. And then over here, you have the left atrium and the right atrium. And then again, you have the lungs, irrelevant. And then this is something going upwards. It's a vein, and it's going upwards to drain into this area here, which is the right atrium. So what could this be? This is the IVC. And so from here you have the SVC, and from here you have the IVC. And yeah, that's pretty much it for the coronal view. Next, you have the sagittal view. This is just looking at it from the side. Again, you have the aorta. We know that it starts posteriorly and goes anteriorly, and this is posterior because you see the vertebral column, and here you have the sternum. So posteriorly to anteriorly, you have the descending aorta, arch of the aorta, and then the ascending aorta. Sorry, ascending aorta. It starts anteriorly and goes posteriorly. So you have ascending aorta, arch of the aorta, and then the descending aorta. Okay, and then most anterior chamber, we have the right ventricle. And then we have over here, you have the left ventricle behind it, and most posterior chamber, we have the left atrium. And then over here, you have the right pulmonary artery, and then the right main bronchus. And yeah, I think these are like very easy, and usually they ask about these, but these are really easy, and if they ask them, that's good. But yeah, that's it for the anatomage. Next, we're going to move on to the physiology labs. So we have the cardiophysiology lab. I'm going to try to spend as least amount of time as possible on these because of time's sake. But inshallah, they'll get you at least like 1 or 2 questions from each physiology lab maybe. So for the physiology lab, this is about ECGs. So you have the resting state ECG. First, you should know that the normal sinus rhythm is when you have a P wave followed by a QRS and then followed by a T wave. So this is when you have a normal sinus rhythm. So in a resting state, this is what your ECG should look like. You have a P wave and then a QRS complex and then a T wave. Now, you have obviously systolic and diastolic periods in the ECG. Systolic is for contraction and then diastolic is relaxation. So the area of systolic is basically from the peak of the QRS up until the peak of the next T wave. So this is the systolic area. And then the diastolic is from the peak of the T wave up until the next P wave. So as you can see, the diastolic period is longer, and this is because the heart needs more time to relax and fill with blood fully. So diastole is longer than systole. And then for inhalation and exhalation, this is also very important. They can get you this ECG and ask you, what is the phenomenon seen here? Or why is this like bradycardia and tachycardia in one strip? So it's basically just inspiration and expiration. So inhalation, what happens when you inhale is your heart rate will increase. Why? Because you're basically increasing your intrathoracic pressure. And so you're inhaling, so you'll have your SVC and IVC will get wider because they'll fill with air. And then the venous return will increase, and that will increase your heart rate. And this is basically sympathetic flow. Exhalation is parasympathetic, and this is when you decrease your heart rate. The way you can think of this is if you get shocked or if you get scared from something, you'll gasp. So you'll do, and then when you gasp, you're inhaling. So that's sympathetic. That'll increase your heart rate. And then parasympathetic, when you sigh, like a sigh of relief, you'll be like, so this is when you're relaxed. So this is parasympathetic and your heart rate will decrease. Okay, so now from resting to standing, this is another thing that you can now recognize. So as soon as you stand, basically, your heart rate will increase. And why is this? Is because when you stand, your blood will immediately pool to your lower limbs. And this will decrease the venous return and cause your blood pressure to fall. And a decreased blood pressure will be detected by your baroreceptors, or it won't be detected. Relax, like there won't be any firing to the baroreceptors. So what they're gonna do is they're gonna fire. So they're like the reflex is going to be increasing the heart rate and blood pressure. So because your blood pressure decreased, your heart rate is going to increase. So that's why from resting to standing, you'll see your heart rate increase from about 87 to up to maybe 115. Only initially, and then it'll go back to normal. But initially, you'll see a increased heart rate. And then these are the formulas. So you really need to know how to calculate the heart rate. So you can either calculate it by counting the large squares or the small squares. Counting the small squares will be more accurate. But if you calculate the big squares, you'll do 300 divided by the number of large squares between the R to R interval. So the peak of the QRS. This is what you're going to count. Sorry, I forgot to write that here. But yeah, you're going to count how many boxes, and then you're going to do 300 divided by that number. Or you're going to do 1,500 divided by the number of small boxes. Obviously, in the OSPE, it would be easier to just count the big boxes. But yeah, they can't ask you this in the OSPE, like calculating. And then also calculation of systolic time and diastolic time. I've never done this in my life, by the way. I don't know like why you need to do it, but it's in your slides, so I guess you should know how to calculate it. So the way you do it is you count the number of small squares between the R wave and the next T wave, because that's what we said the systolic period was, from the peak from the R wave, which is the peak of the QRS, up until the T wave. You'll count the number of small boxes between that and then multiply it by 0.04, because each small square is 0.04 seconds. So if you want to count the systolic time, you'll see the number of squares within the systolic time and multiply it by 0.04, sorry. And then for the diastolic time, again, you're going to count the number of small squares that are between the period for the diastolic, which is the T wave, up until the next R wave. Or it's P wave, but they said P wave there. And then see here, it was the next P wave, and it was. But then he wrote R wave, so I'm not sure what it's supposed to be, honestly. But based on this, it would be the next from the diastolic, the end of the T wave up until the next R wave. This is what this would be, and this is what was in your slides. Sorry for the confusion, but I'm not sure, Saraha. And if you follow this here, T wave to the next R wave, if you follow it here, the period is very short. I mean, to the next P wave, it's very short. It's the same amount of systolic. So Sarah, I'm not sure. But this is the formula that he had. So from the T wave to the next R wave times 0.04. So if you calculate it here, you can either easily calculate the heart rate by doing 300 divided by 4 or 1,500 divided by 2. And then for systolic, again, count the number of small squares between the peak of the R wave and the end of the T wave, and then multiply it by 0.04. Diastolic, from the end of the T wave up until the peak of the R wave, and then multiply it by 0.04. 0.04, yeah. Okay, that's it for this. Sorry, I don't want to spend too much time on it, so you can go over it based on like everything here. Now for the Valsalva maneuver. So the Valsalva maneuver is basically something that you do to, you can test, you use it to test the function of the baroreceptors, and you also do it sometimes physiologically, like if you're defecating or lifting weights or during pregnancy, like during childbirth, the Valsalva maneuver is done. So basically what the Valsalva maneuver is when you forcefully exhale against a closed glottis. So you close your mouth, you close your nose, and you exhale forcefully. This is going to cause changes in your aortic pressure and your heart rate. So we have 4 different phases, and we have different changes that happen in each phase. So we're going to quickly look at each of them. Again, this was explained much more in detail in your actual physiology lectures, but I'll just explain it for the sake of your lab, because you can get asked about it. So the thoracic, so for the first phase of the Valsalva maneuver, this is basically when you first initiate the Valsalva. Initially, as soon as you forcefully exhale, you're basically increasing your intrathoracic pressure. When your intrathoracic pressure increases, you're compressing your aorta. Okay, so if the aorta is compressed, this is going to increase the pressure, the blood pressure, because the aorta is an artery. So if it's compressed, then it has a lot of pressure. So your mean arterial pressure will initially increase. It's gonna like spike up. Okay. And then because of this, your baroreceptors are going to be activated and they're going to decrease the heart rate. So this is basically, this whole thing, you're going to see opposite movements between the aorta and the heart, the pressure and the heart rate, because basically they're just compensating for each other. If you have increase in this, this is going to decrease. If you have a decrease in this, this is going to increase. So this is what you're seeing in the first phase. The blood pressure is increasing and then the heart rate is decreasing. Due to what? Due to increased intrathoracic pressure, which compresses the aorta. Now in phase 2, the high intrathoracic pressure is going to cause a reduce in venous return. Why? Because veins, basically, they move from an area, or blood in general, moves from an area of a low pressure to a high pressure. So if you already have, so if the pressure in the intrathoracic cavity is going to be high, and the atria is in the thoracic cavity, so the pressure there will be very high. So the veins are not going to want to go up there because the pressure is like high. So the venous return is going to decrease. And what's this going to cause? It's going to cause the mean arterial pressure to decrease. Okay, because you have less venous return, and in turn you have less cardiac output. So your blood pressure will decrease. Your mean arterial pressure will decrease. Now again, reflex sympathetic outflow, because you have a decreased blood pressure, you're going to have reflex sympathetic outflow that's going to increase your heart rate. Okay, so remember this. The reason for increase in heart rate in this phase is because of reflex sympathetic outflow. Will increase heart rate and cause vasoconstriction. And then because of this, you can see here that the mean arterial pressure started to decline. It stopped decreasing. Because like the vasoconstriction is going to fix the drop in the blood pressure. Okay, and in the ECG wave for phase 2, you're going to have a shorter R to R interval, which means you have tachycardia, or not really, but yeah, you have tachycardia, you have an increased heart rate. And this is what you're seeing here. And then you have phase 3 is the termination of the Valsalva. So this whole gray area is when you're actually doing the Valsalva maneuver. So you have phase 1 and 2. Phase 3 is when you terminate it. So the opposite of what happened in phase 1 and 2 is going to happen in phase 3 and 4. So in phase 3, what's going to happen is you're going to decompress the aorta. So at first, the aorta got compressed in phase 1. Now you're going to, it got decompressed because you relieved the pressure. So the intrathoracic pressure is going to start to return to normal. The aorta is going to decompress, which is going to drop the blood pressure. At first, it increased the blood pressure because of the compression. Now, blood pressure is decreasing because you decompressed it. And this is going to drop the blood pressure and cause a reflex rise in heart rate. So this is when your heart rate increases. Okay, now the ECG change in this part will be your heart rate, obviously, since it's increasing. So it's going to be slowly going back to normal. So here it was pretty fast, very tachycardic. Here it's slowly starting to increase and get back to normal. So it's about 4.5, the distance between them. Okay, now for the final phase, which is phase 4, here you're going to increase venous return again. So remember in phase 2, we had a decrease in venous return. So it's basically like alternating. First, in phase 1, we compressed the aorta, and then we decreased venous return. Phase 3, we're going to decompress the aorta. Phase 4, we're going to increase the venous return. So we're doing the opposite. Aorta, venous return, aorta, venous return. We're doing the opposite movements in each. So now in phase 4, we're doing, we have the venous return is starting to increase, and blood is able to go. So blood pressure starts to increase because you have more cardiac output. So you have high pressure, and then you have a reflex bradycardia. Very, very important that you have a reflex bradycardia at this point, and you have a decreased heart rate. It's very significant. It's more than you had here. So you have a decrease in heart rate. And this phase can be used clinically to assess the function of the baroreceptors. Because at this point, the baroreceptors get activated when you have a high blood pressure. So the baroreceptors are going to get activated and decrease the heart rate. So they measure the function of the baroreceptors by phase 4. So they make sure that the heart rate decreases by this point. Because if it does, then that means the baroreceptors are working fine. And the ECG change at this point is very high, obviously, because you have a very high, a very long distance between the R and the R. So you have bradycardia. So here it's about 5. He could ask you this as well. So make sure you know all the phases. Make sure you know what happens in each phase with the aortic pressure and the heart rate. Make sure you know what causes the increase and decrease in blood pressure and heart rate, and know the ECG changes as well. Again, this is important for your MCQs as well as your OSPE. Okay, so these are just some past questions I saw on the Valsalva maneuver. It was asking for the systolic pressure in phase 1. I'm assuming that you just calculate it from here, and it literally gives it to you that it's 106. So you say 160. So it's immediately 160. And then what changes in heart rate can you see in phase 1? Phase 1, as you can see, it's let's go back to phase 1. We can see it here. Okay, yeah. So in phase 1, the heart rate is going to decrease. So it can ask you stuff like that, basically. And then what is the phenomenon shown here? Here you have inhalation and exhalation. In X, since you have tachycardia, it's inhalation, and then Y is exhalation. And then you can calculate the heart rate by the method that we saw. And then it's asking which one is parasympathetic and which was sympathetic. Remember, I said when you get scared, you're going to gasp. So you're inspiring, and this is going to be sympathetic. And then parasympathetic is going to be when you sigh, a sigh of relief. So it's going to be Y. Okay, the heart rate in phase 2 increases due to what? Where are we? Phase 2. Phase 2 increases due to what? First, we said it's because of the so this one is because of the sympathetic outflow. So we have increased sympathetic outflow is going to increase phase 2. Yeah, sympathetic axis. What happens to the baroreceptors at phase 2? So as you can see, the blood pressure is dropping and this is increasing. So the baroreceptors are going to get activated or inhibited. Blood pressure is decreased and then, wait. Blood pressure is low, then, okay, yeah, you'll have inhibition of the baroreceptors. And because of this inhibition, heart rate is going to increase. So the lack of activation of the baroreceptors is going to increase the heart rate. Okay. Now for the pulmonary physiology lab, this lab is very, very long. I'm not going to explain all of it personally. I think I'm only going to explain the parts that are probably going to be asked about in your OSPE. So this is basically how you test for your lung volumes. So you have the tidal volume is the normal breathing. And then when you inhale maximally, that is called your inspiratory reserve volume. And then when you rest and exhale as much as you can, the extra air that you breathe out is called the expiratory reserve volume. And then the air that you cannot move from your lungs is called the residual volume. And then your inspiratory capacity is everything from your tidal volume and above. So your tidal volume plus your inspiratory reserve volume. So everything that you can inspire and you have the capacity to inspire is the inspiratory capacity. Functional residual capacity, because it contains the word residual, that means it contains the residual volume. And then it's everything below the tidal volume. So expiratory reserve volume plus the residual volume. The vital capacity, I like to think of this as everything in your control. Everything that you can exhale and inhale is your vital capacity. So aside from your residual volume, everything else is vital capacity. And then total lung capacity is just everything together. Now for to assess pulmonary functions, this we can use it to diagnose restrictive and obstructive pulmonary diseases. What we do is we connect the patient to a spirometer and we cover their nose, we plug their nose, and then we ask them to exhale as hard as they can until all the air from their lungs is out, until they can exhale as much as they can. So this is how it normally looks. And then what data we take from this is the FEV1 and the FVC. So the FEV1 is the amount of air that they expired in the first second. And then the FVC is the total air that they expired throughout until they emptied their lungs as much as they could. So these values, we can use them clinically to diagnose certain diseases, as I said. So this would be the normal. We take the ratio between them. So the normal ratio is 0.8. Now, in a restrictive and obstructive disease, so basically in a restrictive disease, the problem that you have is with taking air in. So you can't take in as much air, so your lungs are restricted, basically. In an obstructive, you don't have problem with the volume of air. You have problem releasing or exhaling the air. So exhaling becomes hard for you in an obstructive disease like COPD. However, in restrictive, you have a hard time inhaling air. So your lungs don't have the capacity to take in as much air as a normal person. So that's why you can see that the air itself, like the volume of air, is much less in restrictive. However, in obstructive, and another thing to note is restrictive, as I said, they don't have problem with releasing air. So the only difference is the volume of air. So it looks the exact same as a normal curve. It's just smaller because you have less air. However, in obstructive, the shape itself looks different. So you can automatically identify restrictive and obstructive based on their shape. Restrictive shape looks normal, it's just less air. Obstructive is less, you don't have a problem with having air in your lungs. You have the air in your lungs, you just have a hard time exhaling it. So as you're trying to exhale, instead of having this like increase, you kind of just have this straight slope. So the FEV1 and FVC in each of them, again, think of this logically. In a restrictive disease, will you have as much air to exhale? No, you have less air in your lungs. So your FVC itself is going to be decreased. because you have less air to أصلاً exhale. And the amount of air, and because of that, the amount of air that you exhale in the first second is going to be less. So your FVC and FEV1 are both going to be decreased, but the same. Yani one is not going to be decreased more than the other. So the ratio, the FEV1 to FVC ratio is going to be the same or even slightly increased. However, in an obstructive disease, you have the problem itself is with exhaling. So you still have the same amount of air in your lungs, and you don't have a problem exhaling it all. You just need more time exhaling it, and you have a harder time exhaling in the first second. So in the first second, you're going to exhale much, much less. You can see the FEV1 is so low in the obstructive compared to even the restrictive or the FEV1, or the normal, I mean. So in obstructive, the FEV1 is decreased much more than the FVC. Because as we said, the FVC is the total air that you can exhale. They don't have any problem with that. Adi, they have all the air in their lungs. They can exhale all of it. It's just difficult for them. So the problem that you'll see is within the first second. So FEV1 will be decreased, and then FVC will be decreased, but slightly. So the overall ratio will be decreased in an obstructive disease. Okay, so make sure you know how to differentiate between the normal, the restrictive, the obstructive, and their ratios. Okay, and now this is another thing, another way that we can measure, and it's by the pressure volume loop. So in the pressure volume loop, again, this is the normal. So you start from here, and then you inspire. So this is you inhaling, and the volume in your air increasing. And then this part is when you maximally inhaled. And then what you're going to do is you're going to forcefully exhale. So this is the peak expiratory flow. So this is the most air that you expired in this, like the highest air that you expired. And then khalas, you're going to slowly start expiring whatever air is left in your lungs. So this is how it looks normally. And in obstructive disease, as I said, again, the same thing that I said earlier here with restrictive looking the same as the normal, same exact thing here. Restrictive looks exactly the same as the normal, except it's smaller. Why is that? Because you have less volume of air in your lungs. Your lungs can't take in as much volume as normal. So you have less volume, but everything else is normal. Adi, you can inhale normally and then exhale normally. It's just less volume. However, in obstructive, you're inhaling normally, and then when you come to exhale, you're going to like kind of face a bump. You're going to try exhaling, and it's going to be difficult for you to exhale. So this is why you have this little thing, this little curve down. So the shape of it looks different than the normal shape. So yeah, again, be able to differentiate these as well, as they can get you any of these pictures. So normal, obstructive, and restrictive. And okay, now again, this is a question: which of the following shows obstruction? So you guys can go over this again later. Okay, that's it. Does anyone have any questions? And thank you so much. And please give us feedback. We would love to hear it, and we'd love to improve anything that you need. And thank you so much, Sarud, for hosting. Sorry to keep you guys long as well.